Welcome to day 2 of Labor and Health. You remember that decorum letter that we didn't read yesterday? We're not going to read it again today. Just be kind. Be nice. It's day 2. If you look at the schedule, you see we're only scheduled till 1. Today, we want to be efficient. We want to get through things. So if you can say it in less words, say it, but let's be efficient. And let's be good. Committee members, it's in your hands. If you want to get home and drive fast, if you want to get home late and drive slow, it's up to you. It doesn't matter to me. I'm only 90 minutes from my house. So with that in mind, welcome everyone. We won't do roll because we're all here. Yep, Senator Barlow is with us. Very good. Welcome, Eric. By the way, Senator Barlow, we were hoping that you'd show us a picture of a newborn, and we haven't seen it yet. So if you don't show us one, it must not be true, because that's why you're not here.
Mr. Chairman, if I could, I've got a heifer calving about 200 yards from here right now. So if I had a better camera, not my flip phone, I could give you a live feed of newborn.
Maybe, Senator, you could just put us on your phone and walk out there. Just kidding. Yeah.
Technology does not.
Oh yeah, the flip phone. Okay. Okay, very good. At some point today, we might get to see a newborn heifer or a newborn calf. That would be very good. Okay, welcome to Labor and Health. Let's start off with provider enrollment. We've got 4 seats. Let's bring up Wyoming Medical, Wyoming Hospital. Let's just bring up whoever wants to come up. First 4, come on up. Or 3.
It's kind of like The Price is Right there. And you're like, next up, let's call on down.
You're the next contestant on. Welcome, introduce yourselves and let's get it started. Go ahead.
Good morning, Mr. Chairman, committee members. Eric Bully with Wyoming Hospital Association.
Good morning, Josh Hannes with the Wyoming Hospital Association.
Good morning, Sheila Bush with the Wyoming Medical Society.
Nope. So this is an interesting topic that we wanted to bring before the committee. We've talked a lot about shortages in healthcare. We've talked about difficulties in recruiting new providers. And as our hospitals, as our practices recruit new providers in, there's a lot of excitement in the communities. There's folks that are anxious to see them and they're anxious to start building their practices. There's a lot of expenses usually incurred in recruiting providers in, with sign-on bonuses, with moving fees and all kinds of different things. But one of the things that our providers have to go through is an enrollment period, along with credentialing and privileging within their hospitals, but an enrollment with the insurance providers. And it can be a difficult and cumbersome process. And the longer those are delayed, the longer those take, the longer it takes for those providers to start being able to see patients and in turn be able to bill and be paid for those visits. And so we were hoping to do what we're seeing happening in other states and get some legislation on the books that protects those providers and builds some assurances in so that we can get these providers to work as quickly as possible and have them reimbursed for their services with the insurance companies. So Mr. Hannes has done a tremendous amount of research. We also have a service that's provided through the Wyoming Hospital Association resources, where we've partnered to help providers not only with the enrollment process, but also with the credentialing and privileging process to speed up that whole process that needs to be done. I said process a whole bunch of times, but that's what it is. So I'm gonna let Josh kind of walk you through not only that partnership, but then also kind of describe to you what we've seen with other legislation and why we think this is important.
Go ahead, Josh.
Thank you, Mr. Chairman. So just for a little more detail, so the enrollment process is when you bring a physician into your facility in the hospital case, they have to apply to be recognized by all the insurance companies that they might interact with. And that's completely appropriate and necessary, right? So that the insurance company knows that this physician works at the place they say they're employed. They have a license in the state, right? They know their specialty. So, say an OB is not submitting bills for open heart surgery, right? This is certainly something it's a needed process to get them enrolled. The problem becomes that every single insurance company has their own application set of requirements and documents that you have to provide. So it's pretty labor intensive on the provider and hospital side to get these done. The other issue is around the time it takes to get them approved. So we're seeing in our state somewhere between 90 and up to 180 days with certain payers to get them enrolled. So the problem becomes if they start working, they can't submit claims for any work they've done. Now, you could kick out their start date and have them start once they're enrolled with different payers, but there's no certainty as to when that's going to get done. Now, what I imagine insurance companies will say is that, we process these very quickly once we have a complete application. So it's totally fair to say if you have a deficient application that has to go back and it should be completed. But the timelines that I'm quoting you are from complete applications. And I just wanted to read, I got this email yesterday, and I'm not going to say which carrier it is, but there was a completed application submitted on April 4th. And as of April 19th, the request had not been issued a processor. So it hadn't been, excuse me, it hadn't been assigned to a person to start the work. And then the insurance company reached back out. This was to Cody Hospital and said that they're still waiting to assign a processor and it's going to take several weeks. This is a high dollar provider. We worked with the insurance company to make an exception to start processing with their temp license as the provider start date is 5/1. And she just received her permanent license 4/26. So these are pretty significant delays with a lot of uncertainty. Now, interestingly, Medicaid and Medicare turn these around very, very quickly. Wyoming Medicaid can do it in a day, excuse me, in a day sometimes. I think the longest average I saw for Medicaid was 30 days, but they're usually in about a week. So we think that if state Medicaid can do these quickly, there's really no reason you shouldn't be able to turn them around in the commercial world. So we provided in your materials a couple examples from 3 different states. I think from our perspective, the state of New Mexico's legislation is one that we prefer, but there's a few concepts I just want to point out in any bill that I think would be helpful. So I think insurance carrier should notify the applicant with receipt of the application within 7 calendar days. So just a notification that, hey, we got your application. Now, if there's deficiencies, those should be sent back within 10 days with a very detailed list of these are the things that you're missing in this application, and then provide them a specific point of contact so they can reach out to Eric at this number if you have questions about what's missing. One of the other pieces of the New Mexico legislation that we think is interesting is that the state of New Mexico requires all payers in that state to use one application. So it's a standardized form. So if you have a new physician coming in, you can fill out that one form and shoot it out to all the different payers they might interact with. Just reducing the administrative burden on the provider side so that you're not filling out multiple, perhaps disparate pieces of information. If the insurance carrier does not provide a receipt within 7 days, the carrier shall be considered a provider no later than 45 days following the receipt of the application. An insurance carrier should process the credentialing and the enrollment application within 45 days. And then once a provider is enrolled, we think that they should backdate their effective date from the time they receive the application. So if you received it April 1st, it takes 45 days to process. If they're doing work, they should be able to submit claims for that work in that time frame where it was being processed. Granted that the application was approved and they were accepted into the network. We think this is really just a process issue. We're just trying to create some efficiencies, make it easier on the provider and hospital side so that people can start seeing providers. These people can come into our communities and start working and then be reimbursed for those services. So that I would leave it at that for now, but happy to answer questions.
Questions for the hospitals? Senator Hutchins.
Thank you, Mr. Chair. This seems really easy. It's kind of like what we did last year with the pharmacists. And I was just wondering, have you gotten with the insurance companies to say, hey, what can you do so you don't have to have legislation?
Go ahead, Mr. Bullock.
Mr. Chairman, Senator Hutchins, we have talked with the insurance providers, and we think that legislation is probably necessary to ensure that there are standards that are put in place shortly after the session ended, actually, probably before the session ended, we started talking with the insurance providers, let them know that we intended to bring this as an interim topic. I'm a little confused right now, but we actually had conversations that talked about the 45-day period and thought we had some agreement there. One thing that I think Josh didn't mention is that New Mexico just worked on this and they actually lowered it down to 35 days in New Mexico. But then it was decided that that's too quick, and they actually turned around, the insurance companies and the providers, and took it back to the 45-day period. But we feel like it makes sense to have this. Secondly, as we look at the standardized applications, the example that Josh shared with you, that's through our service that specialize in getting these things turned around as quickly as possible. So that application was clean when it was submitted on April 4th. And here we are at April 30th, that provider's supposed to start tomorrow. And we're not even sure that it's been assigned an agent to start working on it. And so we think a standardized application would make it more efficient. When you consider how many insurance companies there are out there and little nuances, I think if we had a standardized application process that could be sent out to every one of those would also make it easier. So we're just trying to make it cleaner, more efficient, and make it so our providers can go to work as quickly as possible.
Thank you.
Very good. Further questions? Go ahead, Representative.
Thank you, Chairman Bolden. Thank you for being here this morning. I think I told you last session, if you didn't bring this, I was going to. I've lived through this several times, especially with new graduates. Sometimes they sit for 3 to 4 months and they can see Medicaid and Medicare patients, but they're not going to see my private insurers. And here they sit half the day, which costs me money, and we have patients not being seen. So, and now that it's on a computer and not using carbon copy as some departments do, did the insurance company give you any idea of what they see as a reasonable time frame for turnaround, 35 or 45 or 60 days?
Mr. Bowling.
Mr. Chairman, Representative Clouston, I actually thought we had an agreement on the 45 days. We talked about it, but I'm hearing that may be too quick for the insurance companies. So I guess that's going to be one of the details we need to work out. But based on what we're hearing from a company that actually specializes in this, we think 45 days is pretty reasonable. Once the application is clean, obviously.
Further questions? Go ahead, Representative Penn.
Thank you, Mr. Chairman. A couple of questions. So this New Mexico bill, there's a lot of things in here. And so I'm wondering how many of these things you gave us specifics, which was great to help us know where to begin. There's a few other things in here that I would just wanted to ask about. One of which is on page 5. I think these don't have page numbers, but it's top of the page B, interest on unpaid clean claims. And it says that the health carrier shall pay interest on the amount of any clean claim that's not been paid within the specified time. So I think on this particular bill, this isn't specifically dealing with credentialing. Is that right? This is also talking about other payment once a provider is enrolled. And so the portion of this bill really is more just the credentialing aspect of it, correct? Okay. And there was, let's see. The page after that, delegation of credential verification activities. It says whenever a health carrier delegates credential verification activities to a contracting entity, maybe this is a question for the insurance companies, but I guess I'm wondering what that looks like. Is that something that happens with insurance companies? So whoever wants to answer that, if that's not for you guys, and maybe that can be answered in the future. I guess I'll let you have a stab at that one real quick.
Josh, go ahead.
Sure, Mr. Chairman, Representative Penn. So my interpretation of that is that what they were trying to accomplish in this language was that if the, Acme Insurance Company has subcontracted out that function, that other party is pulled into the legislation so that they can't say, well, that, this doesn't apply to us because it only applies to the insurance company. So this is if their representative is doing that work, that they have to be held at the same standard.
Follow up. Go ahead.
Thank you, Mr. Chairman. Let's see, I know there was one. other thing. I thought there, and again, this is kind of more broad, probably not specific to the actual credentialing process, but does this happen now on that they're credentialed for a period of 3 years? Is that currently where we're at? Once a provider is enrolled, is that a 3-year process, or is that just a New Mexico thing?
Go ahead, Mr. Bully.
Mr. Chairman, Representative Penn, I actually think there have been some changes with that, and I think the insurance company could answer that. I think with some of the transparency laws and things that have been enacted, it might have to happen more regularly than that, but I'm not sure.
We'll save that one for this. It feels like it does, because when I do my credentialing, it seems like it comes up more frequent than that.
But I think, Mr. Chairman, I think the process is pretty simplified in that, and it's more of a ensuring that provider is still in that same practice and the same location. I might be wrong, but we had a conversation about this recently with the insurance companies, and I think that might be part of it.
Further questions, committee? I see a hand. Go ahead, Representative Warnock.
Thank you, Mr. Chairman. Could you explain a little bit about the application process? What's on the application? How big is it? Cumbersome, whatever. And then is the application for private insurance different than the application that you submit for Medicaid side?
Mr. Bully.
Mr. Chairman, Representative Hornick, each application is different. They're not short applications, and the applications for each company, whether it's state Medicaid, whether it's Medicare, or whether it's the private insurance companies would be different. That's why we think a standardized application makes more sense. The information that's requested is pretty similar in each one, but the way that it's framed, the way that it's constructed is different. And some of them ask for more information than others. I can't tell you how many pages because there's dozens and dozens of insurance companies out there, but each one is different. That's why we think it makes sense to standardize them.
Further questions? Senator Bouchard.
Thank you, Mr. Chairman. So rather than making a bill that has everything in it, could we do one bill that just does the standardized form on its own, so we can fix that problem? And then if there's other problems you have to do in a separate bill. And the reason I say that is I like the whole idea of standardized form, because I mean, it doesn't make any sense to have people that are in charge groupthink on one side doing something different on another side. So if we could just fix that, then that seems like a pretty easy bill and easy to, move forward.
Josh, go ahead.
Mr. Chairman, Senator Bouchard. So I agree. I do think that would be quite simple. But I would also say I think it's equally as simple to include the timelines. And because when you're dealing with uncertainty, we don't know when they can begin work, number one, or if you have them begin work, if they can be paid for those claims. Some insurance companies do backdate. They'll go back 30, 60, 90 days, which we appreciate. Some don't at all. And there's even one large national carrier who post dates their effective date. So they might say, it takes 90 days to get them enrolled, but we're not making you effective till 30 days post that. So what we'd really like to see is the standardization issue solved and the timeline solved so that these people can work and care for patients quicker, and we'll have some certainty as to them being able to be reimbursed for that work.
Chairman Swanson.
Thanks, Mr. Chairman. There's no requirement that an insurance company has to cover providers, correct? Like if they're a private company, they can choose whether or not to offer that to any provider, and they're all separate companies. I mean, there's 50 of them sometimes. So, I mean, it just seems weird to me that you would say, hey, you're all separate business entities. You all have, your own processes, whether or not you even want to cover our providers. But now we're going to force you on a standard form that may not be to your own, company's internal pressures or desires to know enough information to want to have to cover those claims. But other states have said blanket form. Medicaid is different, I agree, right? I mean, they're different relationship. But for all those other providers, other states have mandated that individual insurance companies across the board have to utilize one form.
Mr. Hannes, go ahead.
Mr. Chairman, Representative Zwanitzer. So yes, they've mandated that you have to use that same form. they have not mandated that insurance company has to accept them into their network. So I mean, they have that ability to, for whatever reason, deny that, and then, you know, a provider, an independent provider or hospital would have to figure out what to do next with that. But I hope that answers your question.
Thank
Further questions, committee?
Mr. Chairman.
Oh, go ahead.
I was just
Mr.
going to follow up on that. And that's why the application is so important, right? Mr. Chairman, if there's problems with the application, there's a problem with that provider, that gives them the opportunity to say no. But the insurance companies are traditionally trying to build their networks, and a lot of times they're dealing with a hospital that's already in network, and the providers need to be in network. And so we're just trying to make the process easier.
Representative Ward.
Thank you, Mr. Chairman. I think Mr. Foley answered my question. My thought is if they don't like this form, they don't like the timeline, then they might just not enroll providers, but they're incentivized to expand their network. So I think that answers my question.
Don't you agree? Okay. Chairman Swanson.
Thanks, Mr. Chairman. Do any states, as part of the contractual relationship, when a hospital or a provider says, hey, we're gonna, utilize insurance company and have that relationship, in that part of their contractual process relationship, has anybody ever put in the credentialing requirement in that contract in any state? Do you know? That seems to be a more fair, as I'm kind of thinking through this process. That's when hospital A agree to work with insurance company, what's a letter? One, right? And in that relationship, as part of all of the other negotiations and agreements, do you know, would that be more fair? Has anybody ever tried it that way to say, but that might be more onerous on the insurance company too, if they have 47 different contracts with every hospital on a different timeline. That just seems to be a more appropriate place in that relationship, because there's no requirement that insurance companies cover certain providers, except after they've already agreed to work together. Ever heard anything like that?
Mr. Bowley.
Mr. Chairman and Chairman Zwanitzer, I think it's an interesting premise and a good question. The reality is when we recruit a provider into our communities, the intent is for them to be enrolled with every insurance company so that anyone that comes from that community can be treated. So I think it's intrinsic in the contract that we have with that provider. As far as our contracts with the insurance companies, I don't think I've never seen it built in there. And that's why I think maybe this attack at this just creates that certainty and a level playing field across the board.
Go ahead and follow up.
So what happens when you hire a provider, they start work, and maybe they're doing Medicaid patients, and the insurance company comes back and says, actually, we're not going to credential them? What generally, I know that's probably very specific, but in general, what would you do, physicians or hospitals? Would you say, we're sorry, physician, something in your past we didn't catch, or for whatever reason, our largest insurers decided not to do it? What is the process after a denial?
Mr. Chairman, Chairman Zwanitzer, I don't think it happens very often, because normally most of the issues that could preclude a provider from being enrolled are taken care of through the licensing process. But in all honesty, we have some actors that work for us where there are actions that sometimes need to be taken to curtail their business practices. I just don't see it happening very often. Usually insurance companies eventually get this done. In most cases, it's just how long it takes.
Further questions? Senator Hutchins.
Thank you, Mr. Chair. Anybody can answer this. I'm sitting here thinking, you want a standardized form and you have several different insurance carriers that I'm assuming, and I could be wrong, that are giving you a form so that they can fill out for their company. Now you want a standardized form. You're also saying to the insurer, you've got to create a database that's going to match up with this particular form. Have you gotten a form that can be used like that already for each carrier? Does that make sense to you? This form that you're asking them to submit, I'm assuming someone's sitting there database and putting in these fields, filling them out. And now you're saying we want this field to look like this and this field to look like this. That could create an issue as well. Just thought.
Mr. Bowling.
Mr. Chairman, Senator Hutchins, I agree that it'll be a process and it'll take some time. Like we talked about, most of the information that, whether it's insurance company 1 or insurance company A, the information that they're asking is usually pretty standard. There may be some outliers in some of the questions, but the actual format of those applications are different. And so it would probably, just like we did with gold carding, we pushed that out until January of 2026. Maybe what we need to do is, and we're really early in this process, but as we put this bill together, maybe we need to give the insurance companies time to work together to come up with that standardized form. I would imagine with other states enacting this, that there might be a great example. I would also suggest that this company that we partner with, that we use to do the credentialing privilege, could also provide a standardized form that then could be adopted by the insurance carriers.
Further questions? I see one down there, Representative Warnock.
Thank you. Thanks for the discussion. Brings up a couple more questions about the credentialing process. Is it something, the initial credentialing process, it sounds like it might take a bit of time, but the ongoing credentialing process, is it the same form? Is it the same amount of time requirement? Or is it more like a rubber stamp as they go along?
Mr. Bowling.
Mr. Chairman, Representative Hornick, I'm pretty sure it's much easier to re-enroll. And I think the insurance companies can answer that. But from my recollection and experience, it's been a while since I've been in that realm. And we actually had people in our hospital that dealt with that. Seems like the initial enrollment's the difficult part. Re-enrollment is just an updating of information. And you haven't done many of those yourself either, right?
And I will answer that question partially, if I could, Representative Warnock. And mostly, it's not just a rubber stamp, it's an updating of information, like when is your CPR card due? When's your medical license expire? And I do reattestations is what they're called, every month probably, where I have to send information in, and the hospital submits that for me. And that would lead me to another question. How many hospitals in the state actually use the CAQH system? Or do you know? Josh.
Chairman Baldwin, I don't know. We can find out.
I would agree. That would be interesting information for next meeting. Representative Warnock.
Which is what?
It's a credentialing system. It's like a clearinghouse, and it's what my hospital uses, where they collect all my information. So and I like the example of Acme Insurance Company because it took me back to Roadrunner days.
Yeah.
But when they say, hey, we want to be a part of your hospital system, and so then they will submit that to CAQH, and CAQH has all my information. Every provider within our system, they have all that information. So it's one clearinghouse, and then they deal with the insurance company. So it's kind of a standardized form. It's sort of what we're talking about. It's just that not everybody uses that system. But that's what it is. It's a clearinghouse where they collect all the insurance information, and then all the providers have the information there. They deal with it. They just keep track of each provider, each medical provider's information. So the insurance company doesn't have to send a letter to me and to Dr. A and to nurse practitioner B. They just send it to the CAQH, who deals with all of it. Further questions, committee? Go ahead, Representative Penn.
Thank you, Mr. Chairman. So I've been thinking, you know, what if we were having this issue in the private sector and you had a, say you're an auto mechanic and somebody brings you their car and says, my car is not working, and you have a shop that you try to work with and you're continually not getting any response, or it's taking a really long time to get the car back, to get it fixed, or that sort of thing. So your transmission's out, and this company, it takes 3 months to get your transmission back, but this company, if you go down the road, can get it back in a week. The issue we have with insurance is you don't always have a lot of shops to choose from. especially in Wyoming. And so the issue too is if the customer says, I can only pay if you go to that body shop, but that body shop takes 3 months, then we got an issue on our hands. And I guess that's kind of how I'm looking at it, because as a person who wants to support the free market, that's always my first intent. But we do have a difficulty in this state. So would you agree?
They all shook their heads. Okay. Further questions, committee? Okay, seeing none, you gentlemen can take a break. Go ahead, Sheila, the floor is yours.
Thank you, Mr. Chairman. I'm here in part out of solidarity. So Medical Society is obviously involved in this. Our members are the ones being credentialed.
Remind us who you are.
Oh, Sheila Bush with the Wyoming Medical Society. I think that the big takeaway for all of us is the predictability creates efficiency, and those efficiency get people cared for quicker. Representative Penn, in your example, I think it's really interesting because if the auto body shop if I'm the customer and the auto body shop, there's a third party wherein there's this other, it's who the patient has also been insured with, which often patients don't have a choice in. So if they're employed and their employer has provided health insurance, they're insured with that company. And then they take, their car to the auto body shop, and then the auto body shop and the mechanic have their situation. And so you have 3 parties involved and everyone agreeing, rather even than just 2. And so I think it's a great example that the free market just is not how healthcare works, for better or worse. I will mention, Chairman Zwanitzer, you asked a question about, is there any sort of law that compels insurance companies to enroll a provider? And Wyoming does have an any willing provider statute. Thanks. And the Legislative Service Office has done some nice research on this, and the memo is out there. But basically not all states have any willing provider laws. Wyoming does. And that means that any provider who meets the requirements of that insurance company and wants to agree to the contract has to be allowed to be in network with that company. And this is to really, in large part, prevent artificial narrowing of networks, which is something that gets done in other states. It thankfully does not get done here. And so you have competing forces with network adequacy, but also companies in other states can use this principle of narrowing network to their advantage, to prohibit some providers from being in the network and then incentivize paying some providers less per claim by driving volume to them. And so we appreciate that that's not something that happens in Wyoming, and we support keeping the any willing provider statute in place. But that does, I think, factor into the conversation in that there is, in some ways, this statute that compels insurers to allow providers within their network. With that, I'll stand for questions.
Questions for Ms. Bush? Seeing none, I'm partially blind, so you gotta really raise your hand. Nobody's waving their hand. You got off. Oh, go ahead.
If I may, Mr. Chairman, thank you. Just very, very quickly, and we don't have to have a discussion about it, but this morning I passed out to the committee a copy of our 2023 economic contribution analysis of hospitals and nursing homes. I'd love if you all had a chance to review that. I know I shared it electronically with all of you before the session started. Just really highlighting the impact that our healthcare facilities have in the state and as an economic driver in our communities and across the state. Would love if any of you want to reach out and ask questions, certainly willing to do that offline. If the committee has an interest of any time of having me and the researcher who completed the analysis go into more detail and what those numbers mean and where they came from and their overall impact to our state, we'd be happy to arrange that for you.
Very good. And we thank you for that publication. It's a very professional, very good publication. As for the details, I can't tell you, I haven't read it yet, but very good publication. Your members should be proud that you're doing that for them. Very good. Thank you. Mr. Bowley.
Just one final comment, Chairman, when it comes to the proposed legislation in this topic. So as you guys experienced while we were in Saratoga, and this had to do with prior authorization, you heard from a brand new hospital. It had 3 full-time people working on getting prior authorizations completed, and it drives up the expense of healthcare in our state. It's cumbersome. similarly, this enrollment process, also, if we're chasing down this enrollment process for 120, 150, 180 days, it's just another burden that I think could easily be removed. And we have some ownership in this too. We need to make sure that the applications are done cleanly and that all of the information is submitted in a timely manner. And we take that responsibility. But the insurance companies, it's part of their business model to do this enrollment and to get providers within their networks. And the quicker we can all do this, the better we all will be. And so we want to partner with the insurance companies, but we really feel like this is important legislation to make sure that as we're spending so much time bringing all these new providers on, as we recruit, which is so difficult in our state, as we try to address the shortage of healthcare providers, that this may be something that makes things better for them and increases and improves healthcare in our state. So we would just ask that we can move this topic forward and work on it together in the interim and come up with another good product for the upcoming session. Thank you.
Thank you. You can all go have a seat. I bet we have some insurance companies that want to come talk to us.
We'll see how it goes.
Welcome to the table. Introduce yourselves and share your thoughts with us, please.
I hate dead air. Why don't we start off with an introduction?
Go ahead.
I'm going to let Ms. Roday lead off. I am Wiley E. Coyote with the Acme Insurance Company. Bruce Spencer with the Mountain Health Co-op, here to chat with you this morning. Thank you.
Morning, I'm Heather Roday, representing Blue Cross Blue Shield of Wyoming.
Mr. Chairman, members of the committee, good morning. My name is Raymond Redd. I'm with Blue Cross Blue Shield of Wyoming, and we're here to talk about this proposed legislation from the Wyoming Hospital Association. Heather looks like she has her computer ready to go now, so I'll turn it over to her.
Go ahead, Heather.
Thank you, Mr. Chairman. Thank you for the stalling. Okay. So we've had some questions about how the credentialing process works. And so that's what we're going to lead off today with, is explaining how it works from our perspective. Again, this is just for Blue Cross Blue Shield of Wyoming. Not all insurers work this way. So I would just offer that caveat before we get started. So our company, Blue Cross Blue Shield of Wyoming, serves approximately 120,000 members, plus affiliated members for the Federal Employees Program, so FEP, and TriWest, which serves veterans. We will also be providing Medicare Advantage products governed by CMS starting January 1st, and we will also be taking over provider first services for TRICARE, the health insurance provider for the Department of Defense, the Defense Health Agency, good government name, this long. And that covers active military. While we will outline our existing credentialing and enrollment processes, these federal agencies will impose additional credentialing requirements for their networks, which will be applied across the board in the future. In order to sell health insurance on the marketplace, CMS requires our company to be accredited by either NCQA or URAC. We are accredited by URAC, and between URAC and DoD, these are the regulatory entities which set the rules for how we accept providers and hospitals into our network. Providers ask to be part of our network, and they do so either by filling out our specific application or by filling out CAQH applications. And accuracy for the CAQH applications must be attested to by the providers every 120 days. So they have to go in and say the application is complete and accurate, and they have to do it with on a regular basis. When using our application, an automatic reply is indeed sent to the applicant, indicating that the application has been sent to us. We review and validate the applications, and this is what we call credentialing. This is only part of the contracting process that providers need to go through to be included in the network. Now, the main reasons why we credential are to make sure that our network has providers that are qualified by education, training, licensure, and experience to deliver quality healthcare services, to maintain only competent, qualified providers who have not received disciplinary actions, and we validate this through the credentialing process. We have to have these processes in place to maintain a provider network that is in accordance with state regulations, URAC, DOD regulations, and contractual requirements. It is not done to avoid paying claims. The following providers are included in our credentialing programs, so facilities like hospitals, agencies or ancillary practices, think labs, licensed and independent practitioners, and pharmacies are also credentialed, and that's handled through our Prime Therapeutics PBM. To evaluate the quality of providers, URAC requires us to capture 13 data elements. I'll tell you just a few. The practitioner's education and professional training history, an up-to-date history of all licensure, the facility license, history of loss of privileges, sanctions, and disciplinary actions. That's just a sampling. Then we are required to do something called prime source verification, which means we go out to external sources to confirm the accuracy of what was put on the applications, and we must do so with 8 entities, 4 of whom are the Office of the Inspector General, Wyoming State Licensing, the Drug Enforcement Administration, and Malpractice Insurance. If an application is incomplete, we will reach out to the applicant twice asking for missing information, and we offer to help set up one-on-one sessions with them to get through the process. We reach out both by phone and email, and if the applicant is not responsive based on the contact information they give us, then a letter is sent to them indicating their application has been denied due to missing information and they must start over. Once the credentialing process is complete, providers then must agree to terms of a contract before they can be included in the networks. They can't just be automatically added to the network. This enrollment is a 2-party legal agreement. Once we approve an application and a contract is signed, URAC requires us to notify the provider within 10 days of the approval. Now, unique to us, we backdate the enrollment 90 days from the approval date, assuming that the license was valid. So we can't just backdate an application based on the arrival date because the license might not be valid at that time. What we do is we ask for the first date of service to try to make sure that the claims are covered for members. So that's why we backdate it, to make sure that our members are covered. Recredentialing occurs every 3 years. Therefore, the whole credentialing process isn't just limited to a provider once they are in the network. It has to happen on an ongoing basis to stay in the network. Thanks to the Federal No Surprises Act, we must obtain verification from the provider every 90 days that their address is correct. And this is due to requirements about publishing in our provider directories. Our credentialing requirements are indeed listed on our website today. So this is a lot of mandated information that we are required to collect and verify from providers and facilities. And each application requires a signature attesting that it is complete. However, many times our provider relations staff have to chase down applicants asking for missing information. For example, this month alone, April, 122 out of 135 submitted applications were incomplete. That's 90%. Our staff gave us 3 examples where they reached out repeatedly to applicants over 3 to 6 week periods with no response from the applicants. When no response is received, we void those applications. As you've heard, the enrollment credentialing requirements are dictated to us, and we have found bad actors through these protocols and prevented them from being in our network, so that's a good thing. These processes take time, and we do our very best to react quickly because, as has been stated earlier, our members need to see providers, and those providers need to be paid. However, we can't do it without the cooperation of the applicants in the first place. We reviewed the proposed materials, and we have the following comments. Blue Cross Blue Shield of Wyoming does not have delays of 90 to 120 days. When credentialing takes a long time, it's due to incomplete or erroneous applications and non-responsive applicants. At this time, we don't see the value of the language as it is presented because there are no requirements on the applicants to complete their side of the applications completely and accurately. The timelines are being placed only on the insurers when we are reliant on the applicant's information being put in correctly the first time. Language provided from other states includes more than just credentialing. We talked about that earlier. And language from Wyoming would need to be crafted, not just wholeheartedly adopted from other states because their situation and laws are different. If there is any interest in a more balanced approach, we suggest the following elements would need to change. Timelines imposed should start when the applicants are clean and without error, and should not include the time needed for contracting, because contracting is a negotiation unto itself in some cases. Requirements to automatically be enrolled in the network are removed. That's that contract piece. And we can notify providers when we receive or download an application, but they have to put the correct contact information in the first place. And insurers can't be held held liable if they didn't give us the correct information in the first place, which actually happens more than you would think. We would like to remove the 10-day notification rule for missing information. To identify all the missing information, we have to work the entire application anyway, and we can't do that in 10 days. Backdating enrollment can't be done to the application receipt date because licenses may not be valid at that time. We talked about that. We suggest that the overall deadline be longer than 45 calendar days. The time will allow for us to work with providers and accommodate the credentialing requirements of our federal partners, which will likely include more than what is even required today and is out of our control. It will give us more time to get the information back from the external entities which have to respond to our verification requests as it is. So when we talk about a standard form, and we are getting dictated by several aspects of the federal government, does everybody really want to fill out everything that would be required for that if they don't have contracts with the federal government? I guess that would be the question I might ask. So in the current form, we oppose the proposed language and we stand for questions.
Very good. I'll ask the first question because I want to be first.
Okay.
And the first question is this and you may not know this number off the top of your head. How many medical providers of whatever denomination they be, PA, NP, occupational therapy docs, whatever, how many does Blue Cross Blue Shield have in Wyoming that are credentialed through you?
Do you know?
Mr. Chairman, Senator Baldwin, that's a good question. I think anecdotally in Heather's testimony, we heard of 136 applications outstanding. And a lot of times those are re-credentialing applications. And I think Heather touched on this in her testimony as well, that we do have that 3-year requirement. So there is some rules out there that require providers to update their addresses so that we can keep the provider finder updated for our members. But when it comes to provider contracts and how many we have, it's hundreds and hundreds. I can tell you that.
Okay, I would have expected thousands, but we'll go with hundreds. Okay, questions committee, Senator Representative Chairman Swanson.
Thanks. Also, if you know, when these come in, how many are coming in from actual physicians or providers, and how many are coming in from some type of third party that works on their behalf, either like a main contact at a hospital or for like a lab, a national entity that's, batching these to every state at once? And is that where some of the difficulty comes in and replying and getting answers for missing information?
Mr. Red.
Chairman Zwanitzer, thank you. Co-Chairman Baldwin. That's a very good question. And it is a very complex process. So we have providers who are credentialed individually. We have facilities who are also credentialed. And within those facilities, there's also providers that they may credential as part of their facility credentialing process. And these providers and these facilities do have entities that work for them that probably send us information. I don't work as boots on the ground in that particular piece of this, but I do know in conversations I've had with our provider relations department that yes, there is sort of that process where we're not getting the information directly from the hospital itself. Maybe there might be a process going on behind the scenes with a vendor or within a department. So it does become a little bit complex in that aspect. Hopefully I answered your question.
Follow up, go ahead, Senator. Representative.
You can, maybe someday I'll
You
get
can be
there.
whatever you want to be today.
Thank you. That's what I'm known for.
Road.
On facilities, so not only are you credentialing providers, you have to credential that provider in that specific facility because of ADA is a big one. It was when I've kind of looked into this and what has to be credentialed. Certain providers doing certain specialties have to meet certain requirements of that facility, and you have to overlay those. And you have to make sure those facilities, the big one I thought that took a lot of time on credentialing was making sure they're ADA compliant. And if they're not, you have to do more paperwork. And so just a little bit of, I guess my overall question is, how much time do you spend on credentialing providers and how much time do you spend via credentialing facilities those providers work in? And if you know, roughly.
Mr. Red.
Co-Chairman Baldwin, Representative Zwanitzer, that's a good question. I don't work directly in the Provider Relations Department. That's a question that we can take back. But understanding how many contracts we have with providers and facilities, we have a lot more providers than we do have actual facilities and hospitals. So my assumption is that we spend a majority of our time working on professional providers as opposed to facilities, but the facilities do become more complicated. And not to go off on a tangent here, but I think this also answers a question or something that I wanted to explain is that, you know, in working with hospitals and working with providers, it's a little bit different. And in this bill, we're talking about enrollment. And I think that's a question I have about enrollment. As you look at the New Mexico bill, it sort of separates credentialing, it separates contracting. And what we're talking about with the hospital associations right up, they're talking about enrollment. And those are two different things. So when we're working on credentialing a facility, that's a time-consuming process. It's already very expensive for us to go through that. We have lots of staff dedicated to doing it, to making sure we're turning around on time. But in addition to that enrollment process, we have a contracting process. And on the facility side, the facilities like to negotiate those things. It was brought up today that we have an any willing provider statute, which is true, that the hospital facility provider has to actually sign the contract as drafted, but they don't have to, because if they want to be in our network and we want them to be in our network, we certainly have to work with them and negotiate with them. And that takes time. It takes a lot of time to do that. So as an example, if this bill passes and it says we didn't complete the credentialing process within 45 days, and we have to automatically enroll them in our network, we're completely skipping over the contracting process and what that takes to do. They might not want to accept our rates. They might not want to accept our contract as it is. And I don't think we would have a provider in our network who doesn't even have a contract with us. So I think, you know, we're not really contemplating some of these issues, but you know, those are good questions. I'm not sure I'm answering your questions. I think I need to take that back to our folks and ask them those more detailed questions.
Chairman Rudolph, go
Thanks.
ahead.
One more. Can you divide the credentialing process from the contracting process in some format? And maybe you can comment on other insurers as well. Because I think I appreciate that, right? It's a separate negotiation contractual requirement. But is there a way to notify that, yes, your background or your credentialing is completed? Is it separate, or do you just send it all in one big package at the end saying, we're signing off and you're good to go?
Mr. Red or Heather, whoever wants to.
Co-Chairman Baldwin, Representative Zwanitzer, another good question. From the work that I do in the legal department, I know that we have negotiations with the facilities, and those seem to be taking place separately from the credentialing process. I rarely get involved in the credentialing process unless there is some sort of licensing action that's been taken that we need to get this provider sort of taken out of our network, send them a notification, things like that. But when it comes to the contracting process, it is sort of a separate process. And I have been involved in scenarios where we've credentialed a provider, but at the end of the day, that provider did not want to accept our rates, did not want to sign our contract. So we went through the whole credentialing process and did all the work that it takes to do that. But at the end of the day, the provider said, no, thank you to our contract.
Okay. Further questions, Senator Bouchard?
Okay, Mr. Chairman, I'm a little confused because I'm looking at the federal code. And I see the whole credentialing process on that side, which is a requirement for the hospitals. And then I'm looking for something that's saying what you guys are doing, and it looks like your process is all internal. So I don't see the federal mandate doing this to you like they're doing it to the hospitals. So if I'm wrong, please tell me where that code is that specifies that you do something differently.
Go ahead, Mr. Red.
Chairman Baldwin, Senator Bouchard, good question. This was a little bit part of Heather's testimony. So when we operate as an insurance company, we have several lines of business. We have federal business that we do. We have state business that we do. A couple of examples is the Affordable Care Act. The Affordable Care Act is sort of its own line of business. We have Medicare Advantage products that we're bringing to market in 2025. We have TriWest, who takes care of veterans. We also are going to be doing the TRICARE contract, which is for active military folks. And all of these different lines of businesses have their own credentialing requirements. So as an example, the ACA has credentialing requirements that we must follow. And those are within the ACA. And one of those requirements is that we're accredited by an accreditation organization. And that accreditation organization imposes upon us credentialing requirements for the providers. And that's a really great question, because as I look at the New Mexico law and what the Hospital Association is proposing, if you read the New Mexico law further in the credentialing section, there's a second section that allows for a waiver for the health insurance company to not have to follow these rules if they're accredited by an accredited organization, which we are. So from my perspective, and for most of the carriers that I know, we're all accredited, whether it's URAC, NCQA, and a lot of what we're asked to do might fall within these requirements, not all of them. The 45-day rule is pretty steep. And I think we had a 5-minute conversation with Eric about this in front of the governor's office. He may have mentioned 45 days. I do not recall that. We had a 3-second conversation this morning, and I said, I don't think that's what we agreed to. But I think we can work through it. But to answer your question, Senator Baldwin or Senator Bouchard, we do have many requirements in every different line of business that we have. They're not all federal law, because what the federal law does is it points to an accreditation agency, or it's Medicare Advantage, which is covered by the managed care manual that says this is how you need to credential your providers, or TRICARE, who's a government contractor who says this is what the federal government, the Department of Defense tells us that you need to do and the timeframes that you need to follow in order to credential your providers within our network for those active military folks.
Follow up, Senator Bouchard.
Thank you, Mr. Chairman. So if I was looking at 3 different options, how much difference is there between those 3? I mean, because what we're talking about is a more simpler way to do this, that if it's, I mean, come on, we live in a software world where you could check a box and say, this is for this instance, this one is not, and this one's for another instance. And it would even clear those boxes out of that application. This doesn't seem like that hard a problem to me. So I mean, it seems to me that you guys could go back and figure this out with some software engineers and try to simplify this rather than us get in the middle of all this. But I mean, if you guys can't fix it, then I mean, I think maybe we should see these forms. We should see what you're having to collect from different people, because, I mean, there's some people here in business that we would figure it out if we had to do it. So, I mean, and I don't have a question there, but what I except for what are the differences? How hard can it be between 3 different scenarios? How much difference could there be in the information that has to be given?
Mr. Red.
Mr. Chairman, Senator Bouchard, good question. I think that from our perspective, there is already a lot of regulation in this space on the federal side, and some of it is a little bit different. So to move to a standard application would probably be pretty onerous, honestly, on the provider, probably, because it would require more information from them on a standardized basis. And again, we already have requirements that we have to follow. And those are the requirements that we are following. I don't disagree that there may be some bad actors out there from health insurance company perspective. I really don't believe that we are. I think Heather mentioned, we already do backdate applications because we want our members to have their services paid for if they receive them from a licensed and credentialed provider. We don't want to say, sorry, we're not going to pay for that. That to me doesn't make any sense. But to answer your question, I think that there already is a process in place. And the thing that we need to work through with the hospital association on this is, as an example, if I was asked to submit an application to go to college and I submitted the application completely incomplete and expected that the college came back to me and said, Mr. Red, we really appreciate your application, but you missed all of these things, and they have to do that within 10 days. And then if they don't do it within 10 days, I'm automatically enrolled to be in their college. I mean, that to me is sort of what we're looking at here a little bit, right? I mean, the application is incomplete. And so we are required to go through that application within 10 days and find everything that they missed, and then send them a notification that says, these are all the things that you're missing. Please send it back to us. And so that, to me, that process doesn't completely make sense. It's sort of shifting the burden for them to complete an application onto us. And, you know, potentially could be sort of a cost shifting thing too, where we're talking about pay us right away. And if you don't get this done within this really fast amount of time, you're going to pay us anyway. And it doesn't mean that we don't want to pay them. We pay all of our providers as long as they're credentialed, as long as they complete this process. And it is important because if they're not licensed, if some action is taken against them, or they really don't have the liability insurance that they need or something like that, we have to verify all that. And it does take time, and it is very, very important.
Okay, one more follow-up and then we'll move down to Fulton.
Thank you, Mr. Chairman. I don't think we're communicating on the same plane here, because look, yesterday I was looking at all this data that doctors are leaving. And these guys have a serious problem with trying to get them on board. That's the only thing we're not trying to say there's bad actors. We're not trying to say there's somebody trying to pull the rug. We're just wanting to streamline this to help them get people on board so they can have their clients that want serviced. That's where we're at. So, I mean, sir, what is your profession?
Go ahead, Mr. Red.
Mr. Chairman, Senator Bouchard, I'm an attorney, licensed attorney in the state of Wyoming, been practicing for 11 years.
So, Mr. Chairman, I don't mean to be disrespectful, but lawyers seem to create more problems than when we can ever get ourselves out of.
Now, we have a colleague that says the world needs more lawyers.
No, it's okay. I think he's going to be asking me, so.
Okay, go ahead.
Oh, I think.
Go ahead, Representative Clausen.
Thank you, Chairman. I appreciate all your guys' comments. And I think what you've brought up, we can easily work on. If I don't fill out an application correctly, then that's on me, and I expect you to come back and we can work on those timelines. But I appreciate Senator Bouchard's bringing this back to our focus. Our focus is, let's make this simpler for the providers, right? For everyone. I would rather fill out one long form than have to fill out 14 different ones and send them to all these different companies. We should be able to have one form where all the insurance companies can go to or use that form and make this better for everybody. You know, the CAQH thing, it's every 3 months, and I've done it for 32 years. And so do my other 14 providers. I mean, we spend an enormous amount of time going online and saying, yes, all this information is correct. And I know it needs to be. That's not your guys' fault. That's just part of it. But again, it's just some more administrative burden that's on our providers. Anything that we can do to allow our providers to spend more time with their patients is really what we're after here. So I appreciate all your points. To that, when we brought up the 45 days that we heard earlier, did you guys have a timeline that you were looking at?
Mr. Red.
Mr. Chairman, I know, Representative Clouston, sorry. Great questions. And I just want to make sure I at least have an opportunity to say something to the comment that Senator Bouchard made. I certainly am not trying to make this more complicated. And I think what you're saying is, how can we make this less complicated? And I understand that, and I appreciate that. Representative Clouston, I also appreciate what you're saying. I think that we understand that this is a lot of information, but we need it. And I think the Hospital Association even recognized that by saying the forms that they're asked to fill out are generally pretty standard. they're generally asking for pretty standard information. So the information has to be provided. There's no question that it'll have to be provided. So we can have a discussion with the hospital association if there's a simpler way to do that. There's a simpler way to do it online, to have sort of, pieces that need to be asked, and then for a certain provider, if other pieces don't need to be asked, I do think there's a solution for that. But mandating these rigid, timeframes, when knowing that it's a complex process and knowing that other carriers have different processes, sort of flips it on us to say, you figure it out, it's complicated, but we just want to get it done as quickly as possible. And to me, that probably isn't the right approach. The approach would be to work it out, to potentially make it a little bit more of a quick process, because certainly we would want that too. So hopefully I answered your question. I know Heather might have some additional comments about the timing and that type of thing. So I might turn it over to her as well.
Heather. Reluctantly, go ahead, Heather.
Mr. Chairman, thank you. When we talk about how hard could it be, I'd just like to manage expectations. How hard is it for the federal government to make up its mind between Health and Human Services, which is CMS, and the Defense Department, which is DOD? So I think understanding that trying to get those aligned could be tricky. That's all I think that I have. Turn it over to our colleague next to me.
Are there any further questions before we turn it over? Representative Penn.
Thank you, Mr. Chairman. I thought I heard this, but I'll need you to tell me if I heard correctly or incorrectly. But did you say that you do backdate from the time that they're enrolled to when they begin offering services? I mean, it seems like if we can't agree on timeframes, if you say you need more time than what we're discussing here in 45 days or whatever we may arrive at, it seems fair that if the provider is offering services during that time frame and it takes 180 days, and you do end up enrolling, that we would come back and then cover those services. That seems like we kind of killed two birds with one stone. We get the payment that the facilities need and the providers need, but you also have the time frame that you need. So is that something you do?
We're back to killing birds with stones. We're back to Roadrunner. Go ahead, Heather.
Thank you, Mr. Chairman. Representative Penn, yes, Blue Cross Blue Shield of Wyoming does backdate, but the timeline has to be to the point where the provider was licensed, right? So we can go back 90 days generally from the approval date, but we can't go all the way back to the application, if that makes sense.
Go ahead, Representative.
Can we get response on that backdating with other companies as well?
Yeah, let's hold off. We'll get that in a minute when he comes up. That's okay.
Can I just
Go ahead,
follow up again? It was said earlier that Medicaid can turn these around in a day to a week. Do they have the same requirements as you?
Ms. Roday.
Mr. Chairman, Representative Penn, I don't know what Medicaid's requirements are. I just know what ours are.
And I know that we will have somebody that can answer that here in a minute. We have them online. Go ahead, follow up.
Thank you. Last one. Earlier example was said that it took an application was submitted 15 days later. They hadn't heard a response on anything, that it had been assigned a contact or somebody who's working on the case. Could you just speak to that, please?
Mr. Roday.
Mr. Chairman, Representative Penn, I am unfamiliar with that. Again, I don't know what our particular provider relations folks do in that regard.
Okay, it's a half a follow-up. Go ahead.
A follow-up. Thank you,
Go
Mr.
ahead.
Chairman. Do you have a process that you, within internally, you say, we get an application, we'd like to have it assigned to someone to manage this in X amount of time?
Heather or Mr. Red, whoever wants that one.
Mr. Chairman, Representative Penn, we do have a process. I think a lot of it depends on the number of applications that are in and the completeness of those operations. I don't know the exact time frame.
Okay, let's move to the end. Senator Hutchins.
Thank you, Mr. Chair. Heather, you mentioned that the onus is put on you. Could it be possible that when a doctor gets hired at a hospital, let's say he got hired in February and he'll start working in June. My assumption is he's not gonna start working in March or in February. Can they start the process of filling out the application as soon as they're hired? And that onus is on the hospital to say, hey, first thing you need to do is get your application in so that that process can flow a little bit easier. Would that help?
Heather?
Mr. Chairman, Senator Hutchings, absolutely. I mean, if they know that this is coming, then get the application going. Absolutely.
Further questions? Seeing none, let's move down the table, sir. You're up.
Good morning, Mr. Chairman, members of the committee. Again, Bruce Spencer representing the Mountain Health Co-op. My colleagues did a great job describing credentialing from the insurance standpoint. I do need to reiterate again, we are required to credential in order to write insurance in Montana because the federal, and it's a little complicated, the federal government requires us to be accredited. And Mountain Health Co-op uses NCQA, National Committee for Quality Assurance. I hate acronyms. For our credentialing, and they of course have standards for our accreditation, and they of course have standards for credentialing. So I asked right when this came out, because I viewed this more of a, how fast are you getting your credentialing decisions made? So I asked our provider who does that for us, what's your time? And they said between 50 and 60, 65 days. And that's the average. Some providers are going to be credentialed very quickly. Some may take a little time. And here's sort of the idea or the rub. My folks do use CAQH. It's a data clearinghouse. I think you've heard providers log in and provide information. All right. Hopefully that information is accurate, but there's no guarantee. The other problem is that is information coming from the provider, and we are required to verify that information. So we have to go out to the school and get a transcript. We have to go out to the board and get the licensing information. We have to request that the insurer provide malpractice information. We have to go to the board and get continuing education information. In one of the discussions I was having with the vendor that Mountain Health Co-op uses, he says, depending on the specialist or the facility, there are 26 data points that they go out and verify. That verification process is beyond our control because we're relying on some third party to get back to us. Now, Mountain Health Co-op's vendor will do their best to use whatever electronic verification system is available. But let me give you an example. If a provider has disclosed some malpractice allegations against them, and they want and my folks need to go to the court system and see what's going on with that case, I don't think the Wyoming court system, I know Montana's doesn't, allows us to go in and see what's going on with the case. We have to talk to a human. That takes time. So just so you understand, that is part of the conflict that we have, that verification of the information that's input by the physician. I was also told that it's the experience with the vendor that the CAQH information is not always accurate. Now, this is a national vendor. They weren't specifically looking at Wyoming. I'm hopeful Wyoming is more accurate than, say, Florida. But that's, again, why it has to be verified. So there is a time frame there. The other thing that will take long, remember that the average was 50 to 65 days. The other thing that'll take a long time is if you have an applicant that does have, say, a licensure, disciplinary action, or there are a lot of malpractice cases going on. And that's going to require some additional time and effort to view that application to get the information. So the first step of the process is, of course, that the provider sends in their application. A lot of providers are doing that through CAQH or some of the information. But then there is a separate application that they use to get credentialed or re-credentialed with each health insurance company. Then my folks send that out to their vendor. Some people do it internally. My folks send it out to their vendor to do all the verification process. They're going to be asking the provider questions back and forth. I think you heard that the providers use a vendor. Some of them, Mr. Boley mentioned that they use a vendor to do this. So vendors to vendors are talking, and sometimes that communication, I mean, I can see it failing, right? You've got two vendors who don't know the physician or the insurance company who are trying to communicate, and you have some failure of communication. So there's maybe some delay there. But once all that process is done, then actual humans need to sit down and decide whether or not that physician should be credentialed or provider should be credentialed or re-credentialed. And Mountain Health Co-op meets once monthly with its credentialing committee. The majority of the people on that committee are providers, but they go through all of the credentialing applications. And really, to be honest, they're rubber stamping the ones that don't have a problem. They're looking at the problem applications and deciding whether they can credential it or they can't. All right. So once a month they do that. If you miss that time frame, then you've got to wait for the next month's credentialing committee to be approved. Again, there's just some natural delay there. It's not purposeful. It's just the way the system is set up. I would venture to tell you that most applications go through just fine, but there's certainly physicians and providers that have problems, and those are the ones that take time and bring the average up, right? And we have to do it in order to write insurance, okay? I think you've heard, well, Medicaid can do it in 30 days. I believe Medicaid has the ability to offer provisional credentialing. You're credentialed, and now we'll go over here and verify all this other stuff. We don't get that option. We have to verify everything first. Then we have to do a credentialing committee, and then we can credential. And then the network negotiation is separate, right? If you want to join our network, here's the contract, and we can have a contract discussion. So those are just some of the things from Mountain Health Co-op's perspective. I do not know the answer to whether or not we backdate currently, but I can't imagine that it would be problematic. I mean, it's something we program in. I would agree that you can't backdate further than the licensure, because that person isn't authorized to provide the service before licensure. And there may be some other considerations, but I'm certainly happy to find out and report back to the committee. I think there's, my brain's leaving me the break. You, I think, quite properly asked the question, well, why are you in front of us? I mean, why haven't you sat down together, come up with a bill, and then come to us with a fait accompli? I wasn't asked. I wasn't asked to work on legislation to come in front of the committee. I am more than willing to do so. I would respectfully suggest, because this is an extremely expert-intensive area, that you allow us to meet, sort of like we did with prior authorization, and see if we can't come to an agreement. And then we will present you with an agreed bill, but understand that agreement comes with a lot of expert input from both sides. So when that bill is presented, all the experts have said, yes, we can do this, because that's my concern. I have some concerns about any legislative mandate that doesn't have input from the people that are actually doing it. So absolutely, I'm willing to sit down, but I wasn't asked before this committee to do so for the hearing. So the Mountain Health Co-op certainly is willing to work with our provider community. We understand that it's a burden. We're more than happy to work on solutions to relieve the burden. But an automatic entry into the network, when you're the one that has to fill the application out, if there's an error and we don't get it resolved in a certain amount of time, seems a bit draconian to me. Automatic payment of claims seem just draconian to me. It's two separate processes that the service might not even be covered by the insurance company. But there are certainly reasonable compromises that can be met, and we're more than happy to do so. Thank you.
Senator Dockstead, the master of compromise. Go ahead.
I remember compromising with you last summer. It was a long summer. I'm always a little cautious about bills brought that way, but I'm willing to take a look, and you can give us a rough draft. I would like to hear what you see as the end product, but I'd also like to hear from our co-chairs on such a concept.
So, Mr. Chairman, Senator Dockstader, I think in terms of agreement, areas that we certainly can explore and most likely will get agreement on are a universal application. I think that's a possibility. Some reasonable timeframes for getting the process complete once all the information is obtained. I think that those are the things we can compromise and discuss on. I think we're going to have some problems with automatic entry into a network and automatic payment of claims. Those types of things are just, the ability to create provider networks is one of the few cost-saving tools insurance company have. And if that is compromised, we believe it would just cost members, and because we're trying to create some downward pressure on medical costs, and that's one tool we use. And if that is eroded, we get upward pressure on medical costs.
Questions, Representative Ward?
Thank you, Mr. Chairman. Mr. Spencer, you mentioned provisional credentialing, that Medicare or Medicaid allows that. Talk to me more about that. Is that a possibility for you and private insurers?
So Mr. Chairman, Representative Ward, that is not a possibility for us because our accrediting organizations do not permit that. We have to have full credentialing.
Follow up?
Thank you, Mr. Chairman. Mr. Spencer, your accrediting organizations do not allow that. Could that be addressed with legislation? Could you talk to them? How could we perhaps pursue that avenue?
Mr. Chair, Representative Ward, I'm really not sure. I'm not sure that legislation would fix that because these are national accrediting organizations. And remember, the federal government has said that we have to follow their standards. So if the state says you don't have to follow that standard, the federal government's going to say, oh yeah, you do. And the supremacy clause says we win. So I'm not really sure legislation can solve that problem. I would suggest that provider communities could talk to those accrediting organizations and discuss that provisional licensing with them, if that is an avenue they want to pursue. They're in a better position to really talk to the accrediting organizations about that. But frankly, they'd have to convince CMS as well.
Very good. I hope Mr. Springer is listening in on all this because we're going to invite him in here.
I hope so too, Mr. Chairman.
Thank you, Mr. Chairman and Mr. Spencer. So it seems rather unfair for the federal government to allow provisional credentialing, and then private organizations now, they can't use that. That's not an even playing field, and that's not fair. Would you agree?
Mr. Chairman, Representative, I would agree that many things that the federal government does are unfair. That's just the nature of the beast.
Okay. Further questions, Senator Hutchins?
Mr. Chair, you were mentioning, all three of you, about your process.
Can you turn your mic on, Senator?
I'm sorry, Mr. Chair. The process of investigating an applicant. Would it help to just go with what I would again assume the hospital has already done a background check on the individual? So that could help pull back that kind of process on your end, and you could go to the hospital and use their information on their background check. So when they send in an application, background check.
So, Mr. Chair, Senator Hutchings, I think what my vendor is going to tell me is, again, the hospital's the employer or the provider in a lot of circumstances these days. And they're going to say, no, the accrediting standards require us to independently verify the information. We can't rely on the employer of the physician. Those standards require us to go out and verify that the license was done. I agree with you. I do think a responsible hospital or facility is going to make sure their provider is licensed and that they don't have disciplinary actions. But my folks are gonna be required to go to that board and verify that, I'm afraid.
Okay, I'm gonna turn my head this way for a second. Questions on this end? Senator Bouchard.
Thank you, Mr. Chairman. So I have a challenge here. Because we were told the other day that the experts in the room can all sit down together and they can help us get something done. It doesn't look like it's working right now. So my challenge is that all of you guys use all the time between now and the next meeting and bring something back to this committee. So that way we don't have to sit here and listen to all this going around in a circle constantly, because it's really not good. You're going to force us to do something and you guys ain't going to like what we do.
Mr. Chair,
Go ahead.
Senator, if I may respond, I agree with you, but I was never asked to do that before this committee hearing. I'm happy to do that. I would request, however, not your next meeting, but the meeting after. Give us some time to sit down and work through the issues. They are complicated and we do need to reach out to our experts. We're not the experts sitting at the table. We need to reach out to our experts and have them involved. I think we can get there. We got there on prior authorization. It was hard work, but we can do it. I have asked for that opportunity.
I suspect you're gonna get that request, but I suspect it will be before the next meeting. Because we only have 3 meetings in order to get legislation through. So sit on that for a minute. Further questions, committee? See none on this way. Representative Penn.
Thank you, Mr. Chairman. So you have mentioned, or it has been mentioned a couple of times now, backdating to time of licensure, and maybe the hospital association can weigh in on this. I can't imagine that the services are being provided if the individual isn't licensed. And so if we said we would like to see something that's a backdate until time of licensure at least, and maybe also a notice of receipt in 7 days with a attached contact. This is the person who you're going to be working with. I think that sounds reasonable. We're not asking you to go through the entire application and decide if it's complete at that point. It would be nice to see some, discussion about, or a notification if once you find an incomplete application. And of course, I don't think it's fair or reasonable to expect that we start the timeline at the date of receipt, but the date of a complete application. I mean, I think those things sound reasonable. Do you have any comment on that?
Mr. Chair, Representative, those are certainly items that we're all going to be discussing. There's no question about it. And, they probably are somewhat reasonable. I just would need to talk to my experts who actually do their credentialing to make sure they're okay with it, right? I mean, that's fair. But that's all part of that negotiation process. So I sit down with my folks and say, these are the ideas that we're thinking about. Can you do it? What are your roadblocks? What are the problems? And then we all get together in the room and try to incorporate that into a bill that works for everyone.
Very good. Before we go much further, I want to bring Mr. Springer into the room if we can. He's anxiously waiting, I'm sure. Tell us how they're so fast and talk to us about provisional scheduling.
Good morning, Jesse Springer, Deputy Division
Provisional.
Administrator for Healthcare Financing Division at Department of Health. So provisionally, we don't actually do provisional credentialing. So we do the full background check. We check all the licensing boards. We check PACOs, which is the Medicare enrollment database. We check NPPS, which is the NPI database. We check LEIE, which is the list of excluded individuals and entities maintained by the Office of Inspector General. If it's a high-risk provider, which is a type that's designated federally, we do a fingerprint background check with the state board. We check all of the licensing boards for in-state or out-of-state. And so the date we complete that screening is the date we can enroll the provider. So even if it finishes a few days later, we're able to mark the date we screen them under federal law, and all this came under the Affordable Care Act in 2014. So we were, prior to 2020, taking about 30 days or more to enroll providers. And we went through a process redesign, but we've also, through investments the legislature made in our technology systems, we've automated a lot of that checking that I just mentioned. And so, and it's taken waves of refinement there. When we first went live with our new system, we were able to get most done within 5 days. Now we're getting all except some done within 3 days. So our average is 10 hours for provider enrollment. And so to do that, we had to remove steps of the process. We had to automate certain things, like, for instance, the Attorney General used to review every single contract, and we worked with them to review our template, and then it's locked electronically. We don't really consider it an application until someone's actually submitted and signed the Medicaid. It's actually the WDH provider agreement. It's for Medicaid CHIP and for a number of other Department of Health programs. And so we don't actually start the process until they've signed. So I think that is different than was described, that it sounds like they're screening and doing credentialing before the contract. We don't really negotiate either. We have a rate schedule, and we have a rate method for different types of providers, and we have a single contract. That contract's not negotiable. So that is a little bit different than what was described by the private insurers. We have state laws and federal laws in that contract that need to be complied with, and so it's really not negotiable. We only have a unique version that's for University of Wyoming because the state is negotiating with itself, so there are some unique provisions. So I think that's the basics. So I think a lot of it was process redesign and technology. So we've built, like, it used to be that we would manually go check each of these sources. So we'd have to log into PACOS, we'd have to log into NPPS, we'd have to log into the licensing board, and there was a human being doing each of those steps. But what we've done is we've been gathering all the data into our screening database. And so we actually just check those automatically. And so that's why it can be so quick. So we're either in real time or nightly pulling in all the licensing information from each of the licensing boards, so that when we need to use it, we can do it in a more automated way. And we're just using the things that are available on the public websites of the different Wyoming licensing boards. So the ones that can take longer, there's an error on the application, they're high risk, moderate risk. There's some discrepancy on their application between what they put on the application and what's in one of the other federal databases or NPPS that maintains the NPI. Those can take a little bit longer, and so that's where you can have some that go over 3 days.
Very good. Appreciate that information, Mr. Springer. Questions for Mr. Springer? I see one. Representative Hornock, go ahead, sir.
Thank you, Mr. Chairman. So it sounds like you have a lot less required items to check before you approve a credential. I guess my question is, it's good that it's an automated process, but the insurance companies, I'm sure one of the things that they really try to verify is that there's proper protections in place for the patients because of all the steps that they have to go through to verify. Are you checking things like malpractice insurance, past lawsuit type of thing, background checks on the individual, or is that just do you just make sure they're licensed and move on? I'm wondering if there are enough checks. Frankly, your process is incredibly fast, which is good on one side, but I'm just curious the disparity because I want to make sure that the patient is also protected, and you are doing enough due diligence. Not that you're not. I'm just curious what your perspective is on that.
Mr. Springer.
Thank you for the question. I would suggest we're doing as much screening or more screening because we're required under federal law to do additional screening that I don't believe insurance is required, but there are some differences. So we assume that the licensing board has checked that the person has the education to support the license. So we don't go check school transcripts. That's if you think about that, that seems unnecessary. Either the person has been licensed and the licensing board has done its job properly, or the licensing board has not done that. I don't really understand the thought that Medicaid would go do the job of the licensing board. So we absolutely do not check transcripts. Unless, it's a non-licensed type position, but we're not going to check what school they graduated from and those type of things. The licensing board should be doing those things. So if you're a physician, they should have those things to say, this person's able to practice in Wyoming. If the person is a nurse or psychologist, we are trusting the licensing board that they've done that work. On malpractice insurance, we do have those other screenings. We do have events that we're checking, which are contained in PACO, so they could be banned as a Medicare provider. They could be on an excluded list from Medicaid in Wyoming or another Medicaid agency. And they could have things that come up in a background check. But we are not gathering the insurance of the person because, again, the licensing board should be gathering whether the person is properly insured and is maintaining malpractice insurance. So, a lot of these steps should be done by the licensing board and are being done by the licensing board, to my knowledge. And so those are additional steps, but those are the functions of the licensing boards in each state.
Very good. Further questions? Seeing none, thank you very much for coming and joining us today. Okay, committee, we've heard one more testimony. Go ahead, Heather.
Thank you, Mr. Chairman. We were using a couple lifelines to get some answers to some
Hopefully
questions.
They have the right answer or else that would work.
Well, we lifelined it back home. So the question about how many facilities do we have? We have thousands of facilities and 5,204 providers.
So what you're trying to say is the chairman was correct when he said
The
that.
chairman was absolutely correct,
That's-
sir. Mr. Chairman, we pick up applications every day, so there's not a waiting period for that. And then there were some comments about not all providers actually want to be part of the CAQH network. So as we talk about potentially having a forum across everything there, we're going to have to work through that. Do you have anything else?
Mr. Red, go ahead.
Mr. Chairman, just a couple things too. In the testimony from the Hospital Association, the first thing I will say is I apologize if there was any miscommunication on the 45 days. We have worked well with Hospital Association. And just to be fair and to be clear, we did discuss a time frame. The time frame that we've been thinking about is more aligned with what Mr. Spencer talked about, which is 60 days, 60 business days. That would be more appropriate. And if we're talking about backdating, to me, it's like Representative Penn had mentioned, it's not really that big of a deal because we will be paying them. So the backdating piece. Now, not every carrier might like that idea. There could be some discussions with the Hospital Association. This is just coming from Blue Cross Blue Shield of Wyoming. But if we're talking about a time frame, I think I still need to go back to the fact that they will get paid from us from a backdate perspective. And, speeding it up to 45 days to me just seems too quick because of all the reasons we talked about. Once the information is received, I don't think we really have any problems. It's all about receiving that information. But if we do have a bad actor, if we do have a credential that's just really hard to verify, we have to primary source verify these things. I think 60 days is a more reasonable number. And I just want to get that in front of the committee and out loud so that we know where Blue Cross Blue Shield of Wyoming stands.
And I suspect that you're going to have another chance to say it out loud to the committee. Bruce, one final word. Go ahead.
Mr. Chairman, members of the committee, thank you very much. I want to apologize to the committee. My vendor indicated that he thought that Medicaid had provisional licensure, and as you heard, they don't. I will get with my vendor and find out why he told me that. But I want to also share this. I think you heard that Wyoming Medicaid is using more electronic queries to do things faster. Mountain Health Co-op is moving its vendor towards just such a system, and we are hopeful that our credentialing will move along faster as a result. Thank you.
Okay, before we move to my intentions, I'd like to know if there's any more public comments in the room. And
Quickly.
go ahead. What, quick.
Mr. Spencer, you guys did mention, or maybe just you, that you check the transcripts with the school that they attended. Is this a must? You shall do that, or you guys just may do that?
Mr. Chair, Senator, I don't know for sure, but I'm thinking that it's a requirement of our credentialing organizations, because I am pretty sure most private health insurers will check with the educational institution on credentialing, but I don't know if it's mandatory or not.
Okay. Before I tell you what my intentions are, again, I think everybody in the room knows what my intentions are. Is there any more public comment from the room? None from the room. Anybody waiting online that wants to raise a hand and jump up and down? Seeing none. Committee, I'll tell you my intention, and perhaps co-chair can share his thoughts as well. My intention would be is that we have something similar to the prior authorization group. But I would say this, I don't want to have a group of 7 legislators and, 100 public. I would rather keep it a little more limited. Certainly, I think Representative Clausen knows his name is going to come up here, as this is a bill of particular interest to him. What I would like to do is form a group of the insurance companies, the hospitals, the medical society, and anyone else might be interested, and put Representative Clausen in charge. And if there's any other legislator that wishes to help with that, certainly you're more than willing and more than welcome to do that. Would that meet with the committee and then bring that back to us in Pinedale next meeting? Any comments, suggestions, thoughts, disagreements? Go ahead, Senator Bouchard.
Mr. Chairman, I like that idea, but I would like to move forward with a bill draft to start that process. And then when everyone meets and they have everything that they brought to the table, then it's ready to amend and move forward, because we won't get to the end point, without the input from them, but we also need to start the process. So I think including the back pay, some of them back pay, some of them don't. I think that's a driving force. I did not like the one thing I heard was they want to drive the costs down. Well, they shouldn't be using credentialing to do that. I mean, that process, we need to protect not only the providers, or I should say the hospitals. They're trying to put people on board, and the patients, they need the service. So anyway, that's my thoughts, Mr. Chairman. Thank you.
Senator, if you were to make a motion, not that wasn't a motion, but if you were to make a motion, what specific things would you want included on that motion as far as items in a bill that would be drafted?
Thank you, Mr. Chairman. I would like to motion that we draft a bill. The bill has specifically back pay requirements. It also has some kind of expedience on credentialing. And of course, I would also, part of this motion is that the working group brings amendments, compromises to the table by the next meeting.
Thoughts, words? That was a motion. Do we have a second to that motion? We have several seconds. That would be a third and a fourth and a fifth. We'll reward O'Hearn with that second. Okay, discussion on that thought. LSO, is that enough information to put a draft together? I see. Head shake, yes. Okay, no more thoughts? A thought, go ahead, Representative Ward.
Thank you, Mr. Chairman. Perhaps we could include in that draft if the original bringer of the motion considers this friendly, we could include a 60-day timeframe for
What does the bringer think?
You know, Mr. Chairman, I'll defer that back to you because I mean, give me some input on that, Mr. Chairman.
What I will tell you is let's put this, if it's agreeable with the first and the second, that we put that 60-day in just as a number to work with. That may change. But let's put that in the draft as well. Was that okay with the second? Okay. Okay.
I'm good.
Further discussion. Representative Penn.
Thank you, Mr. Chairman. I might add as well, if this is agreeable to the body and the bringer of the motion, that we say that there's a date of notification, whether that be 7 days or 10, and that a contact be provided, that this is who you'll be working with.
Back to the bringer. That's
I'm good.
agreeable. Second? Second was okay with that. LSO, you got that? Okay, that's all the information. Let's have a vote on that. All in favor of that draft bill to be brought forward, please say aye. All opposed, say no. That will pass. We will have a drafted bill for our next meeting. What I would suggest is that group that I asked to get together, you know what's going to be in the draft, that you get together between now and then. And know what your thoughts are, know what your suggestions are going to be. So when we talk about that draft at the next meeting, you've already got it in hand, what we're going to talk about and suggestions that will be made. Okay, thank you, committee. Let's take a break. It's 10:18 right now. We're going to break until 10:30. At 10:30, we will come back and go to agency reports and reviews. Second warning, we're 3 minutes late.
There is a new cow.
Okay, welcome back to session. Our first item of the afternoon, if you'll direct your attention up on the screen. This is the newest member of the Barlow family.
And it's raining. Looks just like it.
Yeah. I don't know if you heard that or not, Senator Barlow, but he said it looks just like you.
Yeah.
Is this the one that was 200 yards from you this morning?
Mr. Chairman, yes, they're still lying out there in the meadow. Yeah, relaxing from the trauma of birth.
Very nice. Thank you. We appreciate that view. So many good things happen in this world, and there's one of them. Okay, welcome back. Yeah. Okay, our final agenda item is agency reports and reviewed. First, we're going to hear from University of Wyoming folks about WICHE and WWAMI.
Which one are we doing first? Or both?
Yeah, we'll just toss them to go. WICHE jumped right in there. So, all right, Kevin can tell us about whatever he wants to tell us about first. If you'd introduce yourselves, let fellow members, that this will be an educational part, if nothing else, for everyone. A lot of times when we talk about WICHE, especially in the legislature, people don't have any idea what we're talking about. So I wanted to give the committee a little bit better idea, as well as an agency report. No doubt in the next year or two, you're going to be talking about WICHE and WWAMI quite a bit. These programs are responsible for a lot of our healthcare professionals, and we think of doctors, primarily, but these have to do a lot more with other things than just doctors, particularly WICHE. And I know we have a WICHE graduate in the back of the room, so we may get him up to tell us a success story. So with that in mind, Kevin, go ahead and introduce yourself and proceed, sir.
Thank you, Mr. Chairman. Thank you for the opportunity to join you today. My first time to Afton. It's a lovely flight in, beautiful. So thank you for that opportunity. We loaded up the UW plane and so yes, I'm going to give you an overview of the WWAMI and WICHE programs, and we have several other folks here that can provide additional expertise. I am the provost and executive vice president at UW. So I always say, if the president sprains his ankle, I come in. I'm the sort of number two fellow, but I have oversight of the academic programs, and including WWAMI and WICHE. I'll also mention, as Senator Baldwin, I'm also a WICHE commissioner, which is one of 3 commissioners appointed by the governor. President Joe Schaefer, LCCC, is the other commissioner. And so we have actually fiduciary responsibility for the WICHE writ large, and we'll be in Vegas next week at the WICHE Commission meeting. So, but that's separate from my role with the university here. I would like to introduce the folks that have joined us today. We have Interim Dean Michelle Hilaire, the WWAMI Acting Director John Williford, the WICHE Certifying Officer for Wyoming is Craig Vasky. We have Alex Keene, Vice President for Finance and Administration. Dr. Rob Monger is the Assistant Clinical Dean from Wyoming, who works with the WWAMI program. We have Vice President for Government Affairs, excuse me, Mike Smith. And then joining us online, we have Dr. Suzanne Allen, who is with the WWAMI program, and Dr. Demi Michelau, who is the president of WICHE. So if you have questions for them, they would be happy to try and answer them for you. So I'm going to again give you a broad overview of what WWAMI and WICHE is, what they are, and then we have Dean Hilaire, who can provide further specifics. First, we'll try to unravel the alphabet soup a bit. What is WWAMI? It's the Washington, Wyoming, Alaska, Montana, and Idaho Medical Education Program. And essentially, we partner with the University of Washington to establish our medical school, which is a collective, again, with the University of Washington and all of its members, and they train medical doctors. And is the WWAMI program is supported by funding from the legislature that offsets a substantial portion of the tuition for these students. So it's a great deal for them financially. Their agreement is that they will return to the state and practice for at least three years. And if they don't, then they have to pay back the investment that the state has made into their medical education program. The Wyoming participation in WWAMI is authorized by Wyoming Statute 21-17-109. WICHE is often confused with WWAMI. It's the Western Interstate Commission for Higher Education. And WICHE, as Senator Baldwin indicated, is an organization that has many components. One substantial component that is particularly of interest to this committee is the PSEP program, which I'll come back to in a moment. But the Wyoming Regional Higher Education Compact is in Wyoming Statutes 21-16-201 and in 21-16-202. So the specific funding that the legislature provides for which he goes into the Professional Student Exchange Program, that's the PSEP, and it offers a broad range of programs and tuition assistance for individuals wanting to pursue these programs, and generally in healthcare. The tuition assistance offered to healthcare professions is much broader. As I indicated, for instance, WICHE PSEP can offer tuition assistance for healthcare professions, not just in medicine or MD, but also provides assistance for dentistry, podiatry, occupational therapy, physical therapy, optometry, physicians assistants, and osteopathic medicine. Assistance toward tuition in any of these degrees leads to a similar return requirement that they must come back to the state in practice or face repayment of the amounts provided plus interest. You're all probably aware that the study of veterinary medicine qualifies for assistance under this program as well, but it does not require a repayment obligation of the student if they don't return to Wyoming to practice. The other main difference from WWAMI is that with WICHE assistance, a student can choose from the list of schools participating in the compact for the degree they desire, whereas all WWAMI students ultimately graduate from the University of Washington from their medical program. Finally, there has been some interest expressed by individual legislatures in the past several years to have UW explore the possibility of direct relationships with the School of Medicine outside the WWAMI and WICHE structure. Most recently, we have been involved with discussions with the University of Utah, already home to several of our WICHE medical school students, about that type of arrangement. And specifically, I have been in discussions with their Dean of Admissions, Dr. Ben Chan, and I'll be going to Salt Lake City on May 31st to visit with him and discuss what opportunities may be available to us. Ultimately, this would be a legislative decision if we were to develop this partnership. Finally, a note about graduate medical education, another area that can cause some confusion. It is a unique entity in itself. Dean Hilaire will address some of the data around this and other programs, including the overall cost, the state of Wyoming contribution as opposed to student contribution, and rates of return of physicians who actually practice in Wyoming. But often it want to keep in mind that it often takes a long time for these investments to manifest, particularly with medical school. They have to go through their coursework, their degree, their residencies, their training, et cetera, to get to the point where they are actually fulfilling the service requirement found in WWAMI and much of WICHE. And that it takes a long time for these investments to manifest, as I said. For example, for a physician, it takes a minimum of 7 years, 4 years of medical school, 3 years of residency. My son just completed his residency, and it seemed like it took forever for him to actually get a paycheck. But anyway, and some specializations require even an additional 3 years of fellowship. So it can be 10 years from the time a student begins their medical school journey until they're actually practicing here, hopefully in the state of Wyoming. So it's a long-term investment. With that, then, I would be happy to answer questions you might have or turn it over to Dean Hilaire for further information.
I see at least one question for you, Kevin. Senator Hutchings, go ahead.
Thank you, Mr. Chair. Sir, I didn't get your name.
I'm sorry, Kevin Carman, C-A-R-M-A-N. I apologize for
All right.
that oversight.
And my question was, in your discourse there, you mentioned that the student only has to practice for 3 years. Is that 3 years after the residency, or is the residency the 3 years?
Well, I hope I got that number right, but it is after the residency. The residency does not count. Some of these students, at the risk of getting out of my lane, some of these students actually do their residency elsewhere and then come here. As you'll hear in a moment, also as part of our residency programs, there are also students that aren't part of these programs that come here and do residencies and do stay here in the state in practice.
Thank you.
Senator Dockstader.
So this partnership you speak of, it's already been under discussion, or you'll initiate the discussion in Salt Lake?
Go ahead, Mr. Carter.
Mr. Chairman, Senator Dockstader, with Utah in particular, it's very preliminary. I've had some phone calls with their dean of admissions. They're interested in talking with us. I know that Representative Larson has had some discussions with them as well, but it's very preliminary, but they are very interested in working with us.
Thank you.
Of note, the University of Utah in the past has had relations with Wyoming, where they had 4 PA slots at University of Utah, and I believe 4 med student spots down there in the past. So it's something that has existed in the past. And again, as Kevin talked about, we do have some medical students down there right now, but it's certainly something that's been there in the past and something we would be reviving. I strongly support it. That's where I graduated from. Further questions for Mr. Carter? Seeing none.
Thank you.
Thank you. So my name is Michelle Claire. So just a little bit of information. I'm going to start with the WWAMI program just from an education perspective. So we take 20 students per year. They start with us in June. So it's not the typical academic type of year position. And they spend their first year and their second year. So they're M1 and they're M2 halfway through. So they spend 18 months with us in Laramie at the University of Wyoming. That's their preclinical type of experience. Then they spend their next 2 years, their M3 and their M4, within a clinical application process. So we have many clinical rotations in Wyoming, but we also have the clinical rotation opportunities in the other 4 states for opportunities. That also brings other students from the other WWAMI communities into Wyoming as well. So we also have them coming back and thinking about potentially wanting to work within Wyoming from the WWAMI program. Just one clarification on something that Kevin said is that our program with the University of Washington is an allopathic medical program. So they're graduating with their MD, which will be a little bit different from the WICHE program where we have both MDs and DOs. So both physicians, just the different type of medical degree that someone can obtain. So one of the things that I think is important as we talk about the state appropriations and the money given to the WWAMI program is to realize that there is a commitment from the students in this. So for example, with our 2023 class that started, they will cover about $273,000. The student in terms of fees has to come up with about $78,000. So they do have a payment perspective that sometimes we forget about. So they are paying into the program. Once they finish, then they go out into doing a residency in any type of aspect. So family medicine, internal medicine, pediatrics, obstetrics, oncology, anything in that aspect. What we then look at is after their residency, they need to come back and work within the state of Wyoming for a minimum of a 3-year time period. The one perspective that you asked, is it 3 years, is if by chance a WWAMI graduate would choose one of the residencies for family medicine in Casper or Cheyenne, it is actually lessened to 2 years. So they have their 3 years that they are doing as a resident, and then they would have a 2-year commitment after versus the typical 3 years that everyone else does have. The average data numbers that we have on that is when we're looking at the 3-year time commitment that people come back, about 61% of graduates come back, work within the state. We also have data that says when we look past that 3-year time period, because there are people that will only come back, do 3 years, they've paid their money and they will leave. But we have about a 79% retention rate of people staying longer than the 3-year time period. I think it's important for this group to know, though, of those numbers, 45% of our WWAMI graduates come back and have some type of primary care perspective. So those being family medicine, internal medicine, pediatrics, or obstetrics. So those are our WWAMI graduates coming back into the state and doing their type of work. So that's WWAMI. MD, that is our allopathic. Absolutely.
Go ahead. Chairman Swanstrom.
So I guess I was surprised. Let me just make sure. You as a WWAMI student, well, not you, as a WWAMI student, you can go into any type of residency or only something that would have a job in Wyoming?
So-
Geneticist, cardiothoracic surgery. I mean, do you have anything at that point saying you want to go do this and we're not sure you're going to have a job in Wyoming? Or is there any check there?
So Senator Baldwin, Representative Zwanzer, there is no aspect that they have to pick a specific type of residency for Wyoming. The way I would describe it is you're asking a 22 to 24-year-old when they're thinking about their future of what they want to do. And many things will happen over the course of their med school years, their residency years of commitment of coming back. So some people will make the decision of repayment. So then we have the WICHE program. So as Provost Carmen alluded to, that has many aspects of healthcare professional programs. So for example, from a physician perspective, we have MDs and DOs. We also have physical therapists, occupational therapists, many other different types of options. And so the WICHE commissioners have an allotment of money, and we are bound by what WICHE says we can give payments of money to. So for MDs, the allopathic, they're given about 54% of their tuition paid for. The others have about anywhere between 31 to 35%. So with WICHE, it is not the full payment method as it seems to be much more with the WWAMI program. So these students are having to take out more personal loans, private loans, other things like that. So that is a little bit different with the WICHE program that we have in that aspect. They also have a 3-year commitment back to the state. The only difference with that is veterinary medicine. So veterinary medicine does not have a commitment back to the state of Wyoming. They can go and practice wherever they would like.
Quick question, because you know this is a focus of mine. Does anyone here, do you know the historical perspective of why the veterinarians do not have a repayment option? Why are we educating the veterinarians who are not coming back to Wyoming?
I do not, Senator Baldwin. I would love the education.
I suspect Senator Barlow may know something about this. If he's still there, so.
I think I brought the bill, so if you want me to.
Yeah, if either one of you, Chairman Swanser or Senator Barlow, who can tell us the best, the historical aspect of the veterinarians.
Thank you, Mr. Chairman. So I was a ESEP WICHE graduate or participant at Colorado State University. So if you want my perspective is it predates me, and I graduated almost 30 years ago. So it's been for quite a while. We've tried to change it a couple of times because I think it's inappropriate. 6 people from Wyoming were in my class at Colorado State. I was the only one that returned to Wyoming. So I actually do have a problem with our current policy. And we had a bill that was vetoed a couple of years ago for maybe practical reasons, but I'd certainly be interested to take up that effort again. Thank you, Mr. Chairman.
Very good. Thank you. Chairman Thompson.
I would just add, we did have a veterinary loan repayment program for any veterinarian, large animal, to move to Wyoming from 2007 to 2016. And when our funding had some issues in 2016, we did away with that program. But on top of the WICHE requirements. But we can bring that back anytime now that we have some funding again, if we need some large animal vets.
And
That's a
now
different
I would
committee.
add to this discussion as a WICHE commissioner is that the cost increase of our WICHE programs is higher with the veterinarians than with any of our other programs. So we've been able to accommodate less veterinarians for more cost. So committee, just keep that in the back of your mind as we proceed. Go ahead.
Thank you. The only other aspect of WICHE that I just want to touch on is that we do have a dental component of WICHE. We also have another program within the state, which is the Y-Dent program, which is a partnership between the University of Wyoming with Creighton University and the University of Nebraska. And so we will on average send 1 or 2 students to those schools in particular. So the Y-Dent program is covered except for students having to cover the fee, and their fee is about $14,000 per year that the dental students have. So a dental student could get into Y-Dent or WICHE potentially, or a medical student could get into WWAMI or WICHE. So just to add a little more confusion to that. And I'm happy to answer any other questions.
Questions, committee? Committee's either getting hungry or tired. Pros, Carmen, go ahead.
Mr. Chairman, if I could just make one comment in my role as WICHE commissioner, and I know we have discussed this, but you heard from Dean Hilaire that we have all of these various programs that the WICHE funds, and then there's the question of how to allocate those funds amongst those various programs, and it really boils down to what is the need of the state of Wyoming, where's the need that needs to be met. I hope you'll agree with me, Mr. Chairman, that as commissioners, we would welcome input from the state of Wyoming on what the need of the state is, and from the Department of Health, et cetera, so that we are allocating these resources wisely that to serve best the needs of the state. As it is now, we really don't receive that input, and we do the best we can, but it'd be nice to have some real data to drive those decisions. Thank you.
Thank you, and I couldn't agree more. Further questions, committee? Go ahead, Representative Penn.
Thank you, Mr. Chairman. So my question is with our relationship with the University of Washington, and how much, I don't know if it's a contractual issue or how much leeway do we have to be able to say we'd prefer our kids not participate in X, whether that be procedurally, clinically, curriculum based. Do we have the ability to say we'd rather not our students participate in these types of activities, or undergo this type of learning, or is it an all or nothing situation?
Go ahead.
Senator Baldwin, Representative Penn. I am going to bring Suzanne Allen on from the University of Washington, but I think one of the perspectives that we need to think about is we are producing physicians that can work anywhere. And so the medical education process is also brought on by their boards that they have to take to obtain licensure. So we need to make sure we are teaching to the licensure exam that they have, but I will allow Suzanne to answer your question specifically.
Suzanne, you're live. You have the floor, ma'am.
Thank you. Suzanne Allen, I'm the Vice Dean for Academic, Rural, and Regional Affairs with the University of Washington School of Medicine. I'm a family physician by training. I actually live in Boise, Idaho, and I have responsibility for our medical education program across the 5-state WWAMI region. To answer your question, as the Dean said, we are accredited by the Liaison Committee on Medical Education. We have to follow accreditation guidelines, which means all of our students have to take all of our required curriculum, and our required curriculum is set for our students to be successful in passing their national licensing exams, which they have to pass in order to receive a license to practice in any state. We do have elective opportunities. Students are not required to participate in any elective opportunities, but they are given those options if they so desire. So I'm happy to answer any specific questions you have about a certain area in our curriculum, but that's just the general overview of our curriculum.
Go ahead, Representative Penn.
Thank you, Mr. Chairman. So I do have some specifics. I know that there's pathways offered, and it sounds like these are, I understand these are probably elective, and so therefore I would assume not required by the accreditation. But the pathways that I have found, there's 6 options. They include, let's see, I moved my. So there's 6, the 2 that I have concern about is one that's entitled Latinx and another that's entitled Black Health Justice. My concern is not because I don't think that we want our doctors to not learn how to care for various demographics, but my concern is the way that these are phrased and what that leads me to believe the underlying root of these are. When we say Black Health Justice, why aren't we just saying treatment of Black people? Why are we saying Latinx? Why aren't we just saying treatment of Latin people? And so that's my concern I worry that there's some DEI creep, and I don't know who is the right person to answer this question, but with our association with the University of Wyoming or of Washington, I just pulled up they have an office of DEI. We know what happened in the last legislature, that our legislative intent is that we are very, very careful about what we are subjecting and exposing our students to. And this is just, I'll just read what it says, that all students, faculty, staff, and university leadership take personal responsibility for addressing our own biases and improving our own institutional culture of diversity and combat racism and inequalities, and it goes on. And so those are my concerns, is our associations with a program that's promoting a lot of these things that in Wyoming, I think we're not palatable to. So I guess I would just like someone to speak to that.
Whoever would like to speak to that. Doctor?
Mr. Chairman, Representative.
Suzanne, would you like to
Allen.
cover that?
Sure.
Yeah, go ahead, Suzanne.
Yeah, sorry. So you are correct that our pathway programs are elective. Students are not required to participate in those pathway programs. Each pathway program is set up generally in the same format, where students take an elective a course, usually in their first year. They participate in a clinical experience working with that particular patient population sometime during medical school. That's the basic general outline. They are largely set up to educate students about working with a specific patient population, so that students are allowed to decide which patient population am I interested in learning more about. So we have an Indian health pathway, an underserved pathway, which is largely focused on rural. As you mentioned, the Black Health Justice pathway, the Latinx pathway. We also have an LGBTQIA pathway as well. So again, no students are required to participate in that. We do emphasize for all of our students learning about health equity or health inequities, and that relates to beyond just demographics. It relates to how does this affect rural populations, and what are health inequities that we experience with our rural populations. Also, we talk a lot about isms. So students who are disabled, patients who are disabled, we talk about ageism as well. So when we talk about health inequities, we're not just referring to racism, but other forms of health inequities as well.
Mr. Chair.
Senator Hutchins.
Thank you, Mr. Chair. I've never heard of these two topics or electives. And just as a dean, I'm wondering, do you find that the bodies of Blacks, Latinos, people that prefer different sexual activities, and maybe Asians and the Indian population, are our bodies different so that we need a specific kind of class to address that issue? Thank you.
Suzanne?
Yeah, Mr. Chairman, Senator, thanks for the question. We do not think your bodies are any different. Actually, we were one of the first medical centers in the US to change how we look at some lab results, where previously there were adjustments made to lab results for people who were Black. And we said, no, actually, that's not right. A Black body is the same as anybody else. And we also know that there are health inequities based on the color of your skin. And that's what we're trying to address so that we are treating everyone the same. And that's true for our rural populations as well. Regardless of the color of the skin, we know that they have poorer health outcomes than people who live in large urban centers.
Okay, follow our Representative Ford or Penn.
Thank you, Mr. Chairman. Could you give me a definition of health equity? When I'm in the healthcare profession as well. We learned about varying situations, socioeconomic demographics and things like that, and how to look for and provide for those types of people in those situations and for various ethnicities and those types of things. I think the difference that I'm trying to investigate is, are our students being trained to look at that from a perspective of social justice, or because these people truly have differences in their physical makeups? Or, we always want to make sure that if we prescribe a medication, the patient has the ability and means to fill that medication. Otherwise, we need to do other things. And so I think we can accomplish that. We can address what you're putting out there as health equity without looking at it from a perspective of what's coming through as more of a social activism.
Comments?
Mr. Chairman, Representative,
Suzanne?
yeah, thank you. Very, very much, we can look at, say, rates of mammograms, right? And you can look at different ethnicities and their rate of mammograms. You can look at rural versus urban and rates of mammograms. And so trying to make sure that we have a similar rate of mammograms across the spectrum of our patients would be what we're trying to address when we talk about health equity.
Okay, Chairman Swan's question.
Thank you, Ms. Allen. So, Representative Penn has the most diverse cultural district in the state, being 66% Native American. Do we have specific programs either through UW or through WWAMI that deal with, in some ways it's health equity, but cultural, medicine as well, and maybe specifics to the Native American population? Do we offer those classes? Are they electives, or do we at least have them somewhere in the curriculum?
Ms. Allen.
Yeah, thank you for the question. Yes, we have an Indian health pathway that is elective, and the Native American, Alaska Native population is included as we're talking about health inequities across our region.
Thanks.
Very good. Further questions? See none. Oh, we got one. You got to raise your hand and wave it and jump up and down. Go ahead, Representative Warnock.
Thank you, Mr. Chairman. So we've heard from basically the program administrators. I'd like to hear from our own university about their feelings on the subject we're discussing with the health equities on this, and if you agree with what the overall program what they require, and just kind of your perspective from the perspective of our university.
Provost Carmen, go ahead.
No, thank you, Representative Harnock, Mr. Chairman. I guess that I have a little bit of learning to do myself in terms of these programs, and I wasn't aware of the specific tracks until hearing about this here. I have to say that when we speak of healthcare inequities as a general topic, it resonates with me. My mother, I come from Western Kansas. My mother died a really slow, difficult death of scleroderma, living in a small rural town. There was a hospital, and there was one physician's assistant that came by once a week. She had to travel 3 hours to see a cardiologist in Wichita, and 2 hours to get to Hayes to see a general physician. And that, to me, is what health inequities are about, is that the access to healthcare. It's less about, and the fact that she lived in that rural environment, by definition, she just did not have access to the same kind of healthcare as if she lived in Wichita or Hayes. So I think that the medical school program addressing and making students aware of these types of healthcare inequities are a very healthy thing to do, and for them to understand the challenges that people in different circumstances may face in terms of getting quality healthcare.
Okay. Further questions, comments? Seeing none. Okay. Any further presentation? You all want to sit down? How about our other representatives sitting there with smiles on their faces?
Mr. Chairman, they said they were happy to stay in their seats if they would. Unless called
Everybody,
upon.
we're all happy to sit in our seats, right? I would mention we have a Lincoln County connection here. Yeah. Yep, you could do anything you want.
I mean,
Swanser.
anything, huh? Thank you, Mr. Chairman. I mean, so part of this information building is what can we do better? What can we assist with? Maybe my question is, when we look at the other WWAMI students from the other states and the percentage of them that go back to their home state, are we equivalent? Are we better? Are we worse? And in a perfect world, I mean, if the legislature gave more funding for more seats, do we actually think we would get more return above the baseline? I mean, I guess part of what I was hoping for the presentation is, here are some concrete ideas that in a perfect world, you're not quite in the agency boundaries of not being able to ask for stuff. So, I mean, maybe you're in some other from, the trustees of not to ask for stuff, but yeah, give us some ideas of, hey, can we strengthen the program? Can we build it? Here's some dead weight. Here's what we'd like. Anything like that you want to bring to us? I was hoping to hear, I guess.
He also would like to hear how we could get more general practitioners trained in OB.
Yes,
Go ahead.
Mr. Chairman, Mr. Representative, or Co-Chair, I'll take a shot at that, but I will, for example, there has been some discussion about expanding the WWAMI program. There's 20 students per year, as you heard, and I think there was even some discussion in the legislature this year about possibly trying to add an additional 5 students. One challenge with that is just the number of students that we have that are qualified for medical school. And we actually feel like we were just discussing this on the way here, that with this year's class, we couldn't have gone to 25 in terms of qualified students at the University of Wyoming if in terms of just qualified individuals. Now, then there's the additional capacity, and Dr. Allen's on the line here, of the University of Wyoming's capacity. They have to be able to accommodate. It isn't just a matter of adding additional students. I have, we had, again, we're discussing the possibility that WWAMI is now limited to Wyoming residents. You heard you were just discussing the idea that some time ago you had a program to encourage veterinarians to come to Wyoming, even if they were not from Wyoming. One possibility to expand that pool would be to make it available to non-Wyoming residents who make the commitment to come back and practice in Wyoming. So just kind of throwing that out there as an idea. Now, also the WWAMI students go through the University of Wyoming. It's with the WWAMI program. There are Wyoming residents who attend universities elsewhere who may wish to pursue medical education and come back and practice in Wyoming. And some of those students are funded through the PSEP program, which we discussed previously. But again, there could be a pool of students that we more actively seek out, that Wyoming residents that say go to the University of Colorado for their undergraduate, but want to come back to Wyoming and practice medicine, that may be a way of expanding the pool.
Follow up, Chairman.
Thanks, Mr. Chairman. I feel like I should apologize before I throw this at you, but when you say there are not more than 25 qualified, why not? Not that I want you to throw our K-12 education system under the bus. But I mean, what is the reason that you don't believe we have the capacity for more qualified applicants? Where in the chain are they not hitting that, what we would hope for as a minimum qualification level?
Representative Zwanitzer, that's a great question, Mr. Chairman. This might be a case where one of our colleagues do need to come up to the table. John, would you be willing to talk about this, or?
Go ahead and introduce yourself and tell us how you're connected to Lincoln County.
I will. So, John Wilford, I grew up in Kemmer, Wyoming. As was noted earlier, I'm the interim regional dean for the Wyoming WWAMI program. I also, as one of the roles that I do for WWAMI is administer admissions. I fortunately don't have to make any difficult decisions on who gets in. The comment on how many qualified applicants we have, I think was noted coming up that I went and looked back at the last 4 years and said if we had had 25 students every year, we would have gotten to a place where we wouldn't have 25. And so some of that is just the population of Wyoming and that you have to be a Wyoming resident, and how many students move through the pipeline and come towards healthcare. So thinking about our enrollment in the College of Health Sciences and what we've seen over time, we've just seen the pool shrink over time. And that is not to say that we do not have amazing students that come to the Wyoming WWAMI Medical Education Program who have come back and are just wonderful physicians. And I cannot wait for many of them that I've worked with to come back. But it's not uncommon for us to have in our application cycle a couple or 3 students that we say, hey, there's a great physician in there. There's a kernel that we can just tell, and they need polished a little bit, and so they'll end up on our wait list this year, and then in a year or 2 they'll come back and we'll scoop them up, and they make a great addition of our class. And so looking at the many years that I've done admissions, if we had scooped all of them up each year, they don't roll forward in time. And so I think that's what that was based on, is just the total numbers that we start with. And if we were scooping 25 a year, we don't have, that little bit of seasoning that they get to go out and become more experienced, to really find who they are before they come and join the medical education program. I hope that answers your question well, Representative Swanitzer.
Well, I mean,
Go ahead.
one
follow
more.
up.
I mean, I guess I want a little more than, well, we just watch it decline over time. I mean, do we need to be recruiting? Is it something you think in high schools we need to be encouraging more doctors? Is there something we can be doing or you can be doing? And tell me if it's the average, right? If our population says, here's how many we believe we get, and that's what it is, that's fine. But, I guess I'd like a little more of saying, we need doctors in the state. Health college is focused on it, and we're going out there and working with anybody interested in high school, or as soon as they come in for freshman biology and they want to be a doctor, because they all do, right up until about you get through organic chemistry and biology, and then it goes to heck and they realize maybe they're not going to be a doctor. Or tell me that we get them to go to physician assistant school or become a nurse practitioner. Yeah, tell me that there's some brilliance on the way to increase the provider population in Wyoming, because as you well know, it's struggling, and we're happy to help, but we think we need the expertise from somewhere else to push something. So anything more you want to give me would be great.
Go ahead, John.
Sure, Chairman Swanitzer, and I might defer to Dean Hilaire a little bit on this too, because I think it's general pipeline towards health science education or health science fields that we're seeing in general. I would love for there to be a more robust pipeline, and we're looking at getting the summer camps going again and some of those things that dissipated with COVID, to get Wyoming middle school students, high school students coming to the university and being excited about the fields that we have to offer. I taught freshman biology at the university for almost a decade, and it was not uncommon for me to see the students who came to the AHEC healthcare career fairs, and we had it be in my biology class at very high levels. And so I think that there probably is partnership to be had, and I don't want to speak out of place here, between the state and the university at how do we really invest in having a greater proportion of our Wyoming middle school students, high school students get exposure to the types of opportunities and fields that we have to offer at the University of Wyoming, and for us to be able to increase our recruiting opportunities to get out into the state more. And that's a place where, just speaking from experience with WWAMI, I'm really proud of our rural and underserved opportunity program, where we have our summer clinical placements, and the students are all over the state. And they get out there and they're working with providers that volunteer their time to have and mentor a student. And You know, we've been in 14 or 15 different communities over the last few years, and you know, it shouldn't just be we need to get everybody to UW, and I think we should, and I think that there's a mission of UW to provide back to the state, but I think also investing in how we get UW out into the rest of Wyoming, and just speaking from my experience of growing up in Wyoming, you know, sometimes it's hard to get to Laramie, and to be at the high school career fairs and things like that, I think goes a long way, but I'll maybe defer to Dean Hilaire on adding more to that.
Go ahead and layer on. He deserves it.
Senator Baldwin, Representative Swanzer. I think what I would say is, so 8th grade is when people are deciding what they think they potentially want to do. And so we need to get to them 6th, 7th, or 8th grade and going out into the communities, having those relationships. COVID was both a blessing and a curse. So we know what it did to healthcare providers. And so some people were energized and wanted to go into healthcare, and other people saw the burnout and decided, I don't want to do 4 years of undergraduate, 4 years of med school, 3 to 7 years of residency before I start getting my official paycheck. And I do just want to make it clear, you do get paid as a medical resident, so you are getting paid. However, I think from a Wyoming perspective, it's not just thinking about physicians. We have nurse practitioners, we have PAs. Utilizing them to their capacity will be important. One of the things that we have been talking about is, it is not just for medicine, it's for all of our healthcare fields, is how do we get these students ingrained into the communities? So when they go on a clinical placement or a clinical rotation, and they spend anywhere from 4 weeks to 6 months, depending on their program, how are they invested in that town that therefore they want to come back in? And I think this is us as the university having to work with the communities, their health centers, their hospital systems, to help establish what is it that they want. So for example, when Senator Baldwin and Provost Carmen were talking earlier, from a WICHE perspective, we have not placed a podiatrist in the WICHE program, so a doctor looking at feet, for several years now. We just cannot seem to get anyone interested in that aspect of healthcare. So maybe there's a phenomenal podiatrist in Wyoming that wants to be the person reaching out and talking to students, but that level of engagement with 6th, 7th, and 8th graders to get them excited about healthcare isn't always just talking. That's not their way of communicating right now. And so we need to be innovative and looking at those kind of things.
Thanks. Okay. Go ahead, Kevin.
Mr. Chairman, I think it would be appropriate to mention here that at your direction, the legislature's direction, we are standing up a physician's assistance program at the University of Wyoming, and we're in the process of hiring a director for that. And so it'll be a couple of years before that program's up and running, but that hopefully will also add to the pipeline of care providers in Wyoming.
Very good. Further questions for the group? Senator or Representative Ward.
Thank you, Mr. Chairman. So I'm wondering, considering in light of enrollment going down, have you considered that the reason might be that some students and parents, especially in Wyoming, find the focus on some anti-science subjects to be disconcerting, and they don't want their children pursuing this kind of anti-science pursuit?
Anybody who wishes to entertain that question? Or even Suzanne, if you wish to entertain that question.
Thank you, Mr. Chairman. I'm happy to share a few thoughts. We know if we look nationally, the number of people applying to medical school has gone down, and that includes in the state of Wyoming. So if the concern was specific to the curriculum in the Wyoming WWAMI program, we would anticipate that that number would go down, but Wyoming residents applying to medical school, say through the WICHE program or going to other private medical schools in the country, that number would be going up. And that number has also gone down. The total number of people applying, at least to MD schools, I don't have the information for DO schools. So that would lead me to believe that this is more of an overall, how are we encouraging young citizens in the state of Wyoming to pursue something in a healthcare field is more the issue, not the curriculum that we're currently teaching.
Follow up, go ahead.
Thank you, Mr. Chairman. Do your accrediting bodies require abortion training?
No.
Okay. Further comments, questions, Representative Penn? I got your name right this time.
Thank you, Mr. Chairman. Two questions. First, do you still require the MCATs for admission on the applications? And second, do you, with, you know, of course, the reason we're doing this is we're trying to increase our physician base in Wyoming. And of course, we want to retain them. We get them back for 3 years or maybe 2 in some circumstances. We get them back for 3 years. And then what happens after 3 years? So my question is, do you know of issues with non-compete clauses? Because we're such a rural state, we get one of our students comes back, working, gives their 2 years, and maybe they want to switch facilities. Maybe they don't want to leave Wyoming, but they want to switch facilities. But because of a non-compete clause that says you can't now work within this mileage, they may have no other options, and then that may force them to leave. Do you have comments on that?
Go ahead, John.
Chairman Baldwin, Representative Penn, I can for sure answer the MCAT question and then maybe give a little perspective on the non-compete. So we do require the MCAT again. So there were 2 years during the COVID window when students couldn't get Prometric test sites that a lot of medical schools nationally didn't require the MCAT. The University of Washington School of Medicine has for, I want to say the last 2, maybe the last 3 cycles. And I could look if that matters to you. So there is not a hardline cutoff or anything like that that exists. So it's a holistic review process. And it's one of the data points as part of that holistic review as students. And do you guys have insight on non-compete that you want to add?
No.
Okay. So I'll just note that we have had physicians talk to us about non-compete clauses, and that it has, to my understanding, occasionally come up on the WWAMI contract review process, but that is all the more I think is within my bandwidth to say. Thank you.
Go ahead, Kevin.
Yeah, thank you, Mr. Chairman. Representative Penn. That's a good question. That does come up from time to time in terms of repayment of loans. If for some reason an individual isn't able to practice in a defined geographic area. I have to say that those are pretty rare in my experience, but they are reviewed on a case-by-case basis, and we try to make the Board of Trustees reviews those appeals and tries to make the best decision that serves the state of Wyoming. But it does happen. But I think I'm aware of maybe one circumstance where that was an issue since in the 3 years I've been here.
And we did have some non-compete legislation 3 years ago, 2 years ago. Representative Clausen.
Just a comment to that. The Federal Trade Commission last week or the week before basically outlawed non-competes unless you're an executive with access to high level information. So as soon as those are actually written in the rules, it's going to really change the non-compete laws in the United States.
Yeah. And I think in most cases, they found that non-competes were non-enforceable. And that's the reason that legislation failed. Go ahead, Representative Hornock.
Thank you, Mr. Chairman. A couple questions on funding. I'd like to know more about the funding mechanism for this. I'd like to know what it costs the state every year over year on average for both the WICHE and WWAMI programs. And then I'd like to know how does that compare to the other states involved? Does the money follow the student specifically? Is that student's tuition, paid specifically to that student, or is the state required to pool the money into the programs themselves? So does the money follow the student? Is the money pooled and then distributed as necessary from from an outside source. Like some more information on all the funding for that.
Go ahead, Kevin.
Mr. Chairman, Representative Hornak, if I could invite Craig Vasky, are you comfortable with taking a shot at that?
Question.
Yeah.
I'll defer.
And as for comparison to the other states in which we make, Demi maybe will give us some answers as well. Craig, welcome.
Hello, Craig Vasky. I manage the budget tracking contract residency certifications for Witchy and Wydent contracts for WWAMI. My day job is a pre-health professions advisor at the UW. We included in the information provided numbers for Witchy, WWAMI, Wydent over the recent years. Last year, Wydent totals were a little over 900,000. No, sorry, wrong line. Sorry. A little over 2 million, of which a little over 900,000 was vet med. The rest was human health care. Those numbers will be higher next year. The legislature increased the budget, so we're able to offer more contracts. We won't have a final number on how many people sign contracts, quite possibly into the fall. So what were the other questions? My apologies. For WWAMI, in the most recent number was 283,000 from the state legislature, and the students make contract payments of slightly under 82,000
For 4 years.
per
student.
per student for 4 years. What were the other questions?
How do we compare with other states? And then maybe.
So with Witchy, it's a set support fee per student. So whether, if an optometry student from Colorado or from Wyoming is funded through Witchy, the school they go to gets the same support fee. And it doesn't matter which school they go to. It's a set support fee, which I believe was another question. So with WWAMI, the money comes to Wyoming. We accept the students. With Witchy, the students apply to whichever of the participating programs across the West they want to be involved in. They see where they're admitted. If they have multiple acceptances, they get to choose the school, and the money follows the student.
Further questions? Not seeing any hands. Oh, I see a follow-up. Took me a minute. Go ahead.
Could you just give that figure again, the per student per year cost that you mentioned?
For which program?
Well,
For
actually both. They were different, but
So, John will give you the WWAMI numbers in a moment. For Witchy, it is program specific.
I don't have the Witchy.
It ranges. I have notes, but I appear to have misplaced them.
Some of this is in your
Yeah.
provided materials as well.
So for a medical student in Witchy, it's going to be 35,000 for MD. For DO, it's going to be 25. If we're talking occupational therapy student, it's 15,300. And those are per year numbers. So it varies pretty widely on which field they're in.
Very widely.
Hugely,
Yeah.
yes.
John has a number for WWAMI?
Yes, Chairman Baldwin, Representative Hornak. So on the handout that you have, there's a table of the Wyoming WWAMI cost. And so I just very quickly divided each of those numbers by 4, because as noted, that's the 4-year cost. So it's roughly $70,800 per year that the state appropriates, and then $20,500 that the students pay. And again, if the students come back and practice in Wyoming, it's that state appropriation that is forgiven. If not, that is what the students pay back, should they not return and practice in Wyoming.
Very good. Further questions, committee? Seeing none. Gentlemen, you're off the hook.
Thank you.
And one person got to stay in his chair and didn't have to get up.
But Mr. Chairman, I would say, because it's an all interim topic, if there is some ideas or in a perfect world, you'd like us to look at something, next couple of months while there's still some meetings, I would at least be happy to entertain any type of wish list that UW will let you give us.
Is there any public comment on the Witchy or Whammy programs from UW? I see one in the back. Somebody who participated in the Witchy program. Come on up, doctor. Nice tie, by the way.
You guys in ties in this county.
Okay, there we go. Good morning. Thank you, Mr. Chairman, members of the committee. My name is Kobe Ramsey. I'm an optometrist in Rock Springs, Wyoming. I'm a native from Rock Springs. I was lucky enough to have receive the Witchy scholarship when I was accepted to optometry school in Oregon in 1989. I did do my undergraduate out of state, and when I called the state of Wyoming, they couldn't have been more helpful to help me fill out the application and tell me all the things I needed to do. So I was very appreciative to the University of Wyoming taking care of me, even though I was going to school out of state. Having the Witchy funds was a great benefit to me and my family. I paid for half my tuition while I was there for the 4 years. And while I was there, I worked full-time at a bowling alley, and I also was a TA for an ocular anatomy class to help offset some cost. So I was very grateful that I did not need to take more money out for tuition in loans. When I graduated from optometry school back in the Stone Ages, I was nearly $60,000 less in debt than the class average that I graduated in. This also meant that it was easier for me to get a loan to open my practice since my debt burden was so much less than my peers. I was also able to pay off that amount much sooner. The best part was coming back to practice in my hometown in this great state of Wyoming. I would request that this program remain in place to help those going to doctorate level education. We are a physician shortage state. With Witchy, there is an incentive to return to our state and help care for those who made it possible for them to afford their schooling. As in all rural states, it is becoming more difficult every year to find doctors that want to work in a rural setting. I feel that with Witchy, there is a financial incentive to practice in Wyoming. Thank you again for letting me participate in the Witchy program and allowing me to speak today.
Thank you much, doctor. Don't run away because I'm going to ask you a question. Of all the optometrists that you're acquainted with in the state, and I know you know most of them because of what you do, how many or what percentage do you think are actually having gone through Witchy, or how many are you personally acquainted with?
Mr. Chairman, thank you for the question. I believe that when I sat down, I was thinking about that the other day. There's not as many as you would think. There's only a few of us. And I think part of the problem is something we discussed is they didn't even know about the program. And so I think a lot of the optometrists don't know about the program. And then some, if they go to school out of state, they were not aware that they could still apply. So I would tell you, if I was going to make a guess, I would tell you it's probably under 20%.
Very good. Thank you. Further questions, committee? Representative Warnock.
Just curious, if there is, I don't know, business is tough in Wyoming sometimes, our population and things like that. I'm curious if you have an idea of doing business, choosing to stay within the state. I know that there's some financial incentives with your schooling, but do you think the pay rate generally in the state of Wyoming, if people choose to come back here, is equivalent with other states that they could go work in?
Mr. Chairman and Representative Hornock, thank you for that question. I don't think you want to spend as much time as that answer will take. I will tell you that it depends on if you're talking in my situation, do I take vision discount plans, or are you talking about the medical end? Because we do both as optometrists. So we take care of medical and we also take care of vision discount plans. So a lot of those are set when you sign the dotted line, and some of those plans are nationwide and they're about the same reimbursement in all the states. The reason to come back to Wyoming is not only is it a great state to work in, also do get a little bit of incentive if you bill Medicare, because we are a physician shortage state. You get a little bit extra when you see Medicare patients, when you get reimbursement. So there is a little bit of incentive to come back to Wyoming in that regard. So if you want more, I can probably talk to you afterwards if you'd like.
Pretty good. Further questions? Seeing none. Thank you very much, Dr. Ramsey. Further public comment? See none online, I assume. Okay. Let's move on to our final item on the agenda, and that's Wyoming Department of Family Services. And I believe Corinne's online. Oh, there was one hand up.
Demi wanted to say something.
Oh, Demi.
You can pull her in. Pull her in.
Demi, as soon as you can hear me, the mic and the floor is yours. Go ahead,
Mr.
Demi.
Chairman, can you hear me, Mr. Chairman?
Yes, ma'am. Go ahead.
Thank you. Thank you for the opportunity to speak in public comment. There was first of all, for the record, my name is Demi Mikolau. I'm the president of the Western Interstate Commission for Higher Education, or WICHE. And there was a question earlier in the hearing about the comparison of the appropriations to PSEP between the states in the West. And I do have that data. I will share that with you, Mr. Chairman, so that you can share that with the committee. But just briefly, Wyoming is probably most comparable with Montana. The appropriation for Wyoming is just over $2 million, and Montana is 2.6. And also in somewhat comparable is New Mexico, which is at 1.8. Arizona appropriates the most at 3.9 million. And I will share that data with you so that you can share it with the committee. And one other comment is that and I think it may have been mentioned earlier, but we just completed an evaluation of our PSEP program. And much like the comment earlier, if there is anything that you can all think of that WICHE can do to make PSEP more effective and useful to the state of Wyoming, please, by all means, let us know. Thank you for your time.
Thank you, Demi. Any questions for Demi? Nope. Representative Horlock, go ahead.
Mr. Chairman, thanks for that information and some clarity on that. Now with that, are the number of students enrolled per those states equal to Wyoming? Is there more from Arizona? Is there more from Montana, which pays a little bit more? Or is it, how does Wyoming compare numbers wise with students enrolled in these programs compared to the amount of money we spend per student?
Go ahead, Demi.
Mr. Chairman, Representative Hornock, they are somewhat comparable. If you recall from how the program is structured, the support fees vary by field. So depending on which fields the state has decided to support, that can vary a bit. But just listing those three states that I mentioned, Wyoming supports 80 students for just over $2 million for 2.6 million. Montana supports 91 students, and at 1.8, New Mexico supports 59. Arizona, on the other hand, with 3.9 million, supports 143. So it does correlate, but it's not an exact science.
Very good. And I would add that it depends on what states have what programs within their state. For Wyoming doesn't have veterinarian. We don't have a medical school, et cetera. Some states have a veterinarian school. They have an optometry school. So what they desire is much different than what Wyoming desires. So any further questions for Demi? Seeing none, thank you very much for joining us. We'll see you in a week.
Thank you, sir.
Oh, okay. I see another face online. Is that someone coming to visit us?
It's Director Schmidt.
Oh, it's Corin. Oh,
Yeah, the glasses.
see, you have your glasses on and I don't have glasses anymore. The combination didn't work, Corinne. Okay, go ahead. We're talking about Department of Family Services. Corinne, go ahead and let us know everything that's on your mind.
Oh, boy.
How much time do you have, Mr. Chairman? Thank you, Mr. Chairman, Mr. Co-Chairman, members of the committee. My name is Corin Schmidt. I'm the Director of the Wyoming Department of Family Services. I appreciate very much the opportunity to present via video. We have a health condition in my family, so I think the conversations today, yesterday, are very timely in just understanding how to navigate healthcare system with an aging parent. We were invited today just to talk about some program and policy updates. I didn't receive anything specific. So what we decided to do, if it's okay, is to present basically our strategic plan. And as we go through the strategic plan, then highlighting some of the programs and some of the initiatives that we have. We provided to you the Department of Family Services Strategic Plan Overview, which is either a 1-page or 2-page document, depending if it's front and back. And it's a quick summary of our strategic plan. If you have the document available electronically, there's a hyperlink at the bottom of the first page where you can then link to our larger strategic plan. In front of you today, you have Roxanne O'Connor, who's kind of standing in as my proxy. She'll be available to answer some of the questions if there's any technical difficulties. And then we also have available the rest of our DFS team if you get into any questions where we need a little more detail. Just a quick overview of our strategic plan. This is a required document per statute that goes along with our budget. It's submitted, the strategic plan is submitted in August of every odd year, and then annually we provide an update. And I think all those documents can be found on the State Library's website. Last year, as we started to put together our budget and exception requests, we also wanted to take the time to reset the agency a little bit and get us refocused. As you know, COVID threw everyone for a loop, and it threw us for loops in ways that are probably never going to be fully understood or explainable. However, it did really disrupt a lot of our labor market, a lot of the services we provided, and a lot of the work the offices do or that we do through program and policy. So the strategic plan was a way for us to align so many of the activities we had underway and put them in some time frames, and then to organize them underneath basically seven types of goals, 7 buckets, if you will. So today, what I'd like to do is just talk in general about the strategic goals, the operational goals, and then give you a little bit of information. If you turn to page 2 of the handout, you see a very condensed high-level summary of what's in the actual strategic plan. So this is just a cheat sheet for you to be able to kind of look at a reference so you don't have to dig through the whole document. The whole document is fairly long. This was just our way of trying to make it a little more succinct. And then you'll see that there's current and planned work initiatives, and then some determinations about how we intend to measure success. Much of this work, as I mentioned, is underway, but we are formally putting into place the performance measures starting at the beginning of the biennium, which is July 1st of this year. So while we have some performance measures identified, the actual data collection baseline establishment will be July 1st. So, Mr. Chairman, Mr. Co-Chairman, if you're okay with that type of approach, I can start to walk us through it.
That's great. Proceed.
Okay, so strategic goal number 1. So you see that they're kind of divided into 2 sets of goals, strategic goals and operational goals. And this was our way of trying to balance out the work that the entire agency does. So a lot of our strategic goals are really around services, service delivery, program policy. Our operational goals are those kind of administrative functions that we need to have in place, that we need to make sure are neat and tidy so that we can deploy our strategic goals. So that's why you see them broken down into kind of 2 different sets of goals. So the first goal, our first strategic goal, is to safely decrease court-ordered placements. Safely decreasing court-ordered placements for us really means that we're doing more to keep families safe at home. And that may be families with abused and neglected children, that may be or at risk of abuse and neglect, that may be children in need of supervision, or that may be juvenile delinquents. Also added to a larger part of the conversation now are our vulnerable adults. So this is our collection of services in partnership with our communities and partnership with all the programs we offer to be able to think more about how we can keep children, families, vulnerable adults safe at home, recognizing that if government intervention needs to occur, that we want it to occur because there's a high need, and that the services after that then are certainly less voluntary and more dictated. So safely decreasing the number of court-ordered placements for children is the first place where we're looking, children and families. So how are we going to do that? One of the ways that we're, one of the methodologies we're deploying across the whole agency is called motivational interviewing. And motivational interviewing is just a technique and a way to be able to engage with clients or with colleagues, whereby it's a line of questioning that helps then to figure out what it is that that family may need to be successful. So it's one of the recognized interventions on the Clearinghouse for Prevention Services, which is kind of a minor detail, but important to know that there may be some funding that we can pull down from the federal government to support that. But as an agency as a whole, we recognize that finding out what families need, when they need it, and getting it to them will decrease the chance of abuse and neglect, but it also decreases the length of stay that they have in any of our programs. So it's the right service at the right time component. This is, as I said, being deployed across our agency. It already exists in our child support program. It's rolling out in our social services programs. And then the rest of the strategies will look at how we engage or use those types of interventions throughout any type of our activities in the agency. Another way that we're looking to reduce the number of placements also comes from partnering with the Department of Health on the behavioral health redesign. And I know this committee has heard a lot about that. Certainly we've been excited to be a part of those conversations because we recognize that as, again, a direct service to a family when they need it. We see a proportion of children that come into care because parents aren't able to access mental health and substance use services. So part of the behavioral health redesign will help us develop, I think, a clear pathway to obtaining those services for families and also for children coming back into communities, helping them to be more successful when they do come back to a community after a high level of therapeutic intervention. And then increasing economic supports and other concrete supports for children who are leaving care or children who are leaving facilities. So we talk a lot about the front end of our social services systems. We talk about children who've been abused and neglected when they come into care. What we're trying to do is also have a focused conversation about children who leave our care. So unfortunately, there are times when children do not have some sort of permanency option where they can go back home to a family. And even if they do go home to a family, sometimes they're at an older age where they're on their way to becoming young adults and on their way to become living on their own. So we want to make sure that we're equipping them the best that we can to be able to reintegrate into the community or to have some of the services that they may need to get them started. The boys' school and the girls' school is focusing a lot on that transformation back into community, looking at the skill sets that they have, that they've gained through the course of their stay at the boys' school or the girls' school, and then thinking more concretely about what are the services they need so that when they do go back, they can be more successful. Moving on to strategic goal number 2, increase concrete economic supports and community-based supports for individuals and families served by the department and its partners. And this is where we see the beauty of all of the programs that we offer throughout our agency coming together. And it really does provide those opportunities for success. A lot of the families, a lot of the individuals we engage with have a higher level of need of some sort. They may be in crisis. There may be a lack of skills. There may be a lot of chaos. There may be mental health or substance use disorders. It may be due to age or some sort of disability. So when we think about this goal, we're thinking about pulling from everywhere in the agency, but also recognizing that communities are really the key partner in this. Communities, we really believe that communities understand and know their communities better than the state ever will, but through our local services and our local departments, being able to provide support to any of those community initiatives and efforts so that they can engage with families, and then therefore the state doesn't have to. So some of the ways that we're supporting those efforts, one comes around the plans of safe care. This truly is a community-based group effort. And our goal is for the department not to have to get involved with those families. By working with those families, those parents, on a voluntary basis at the time of birth, if there's been a substance-exposed infant, getting services to that parent and those parents and getting services to that child is important. Certainly, if we need to become involved, we will, and there is a referral system for that. But we also recognize that one of the best chances for continued success of that family is if they stay together in the first place. We're looking at reducing barriers, more administrative barriers to any of our services. We learned in COVID that the way that we do business is pretty difficult. And I think that prompted us to do a lot of review and thinking about how it is that people can apply for benefits and then how people receive benefits. So knowing that we're a state that prefers small government, we really did focus and have been focusing on how do we do what we can do better without more people. We've been going through a series of business process redesigns. We are looking at right now a lot of what's happening with our SNAP and TANF applications, and are finding that we can, through a new process that's evolved through this redesign, get benefits to people who are eligible almost immediately or determine eligibility almost immediately. So whereas it could take up to 30 days, we're doing it in less than 7 to 5 days. And so what that means then is it's the right services at the right time. If we can prevent some level of chaos by getting somebody food that they're eligible for and they meet the criteria, then what we're again hoping is that it reduces the chance that that family will come to further attention of the state. Our child support program continues to be #1 in the US. This is the 11th year running, so we're very proud of that. I had mentioned that they do motivational interviewing. That was one of the places where we've seen motivational interviewing really work well, and is one of the reasons why we're also looking at expanding it across the agency. Our work participation rates in TANF exceed the national averages by a lot. So we're very proud of that. In Wyoming, the 2-parent participation rate is 74.5%. Nationally, it's 44%. For all families, our participation rate is 74.5%, and nationally it's 35.6%. So we're doing a great job of getting our families, our TANF clients, engaged in some sort of work program. And a lot of that is due to the partnership with the Department of Workforce Services, who provides a lot of employment support for our TANF families. And then also looking at our SNAP outcomes, we see that we're one of the top 3 states in terms of a low error rate. So what that really means is that we're paying very close attention to the details of the cases. We are addressing errors or even avoiding errors at the very beginning, and certainly appreciate the work that our local staff give to that attention to detail, because it then does make us a lot more effective.
Corinne, I got a quick question for you here.
Sure.
Senator Hutchins, go ahead.
Thank you, Mr. Chair. Corinne, can you tell me what's involved in the motivational interview? So, and why it's so popular or so good that you want to share that? Thank you.
Go ahead, Corinne.
So motivational interviewing is a way to engage and ask questions that allow the participant to really kind of think about what they want to say and offer that. So what we find in a lot of kind of health and human services is we ask questions that are more check mark questions, yes or no questions. Basically kind of the forms. What this does is it teaches us how to engage a little bit more to understand truly what the needs are through the eyes of the person who we're speaking with. A lot of people come to us thinking they want one thing, but what they actually need is maybe something else. But because they don't know our systems, they don't know our language very well, meaning all of our bureaucratic language, sometimes asking questions in a different way help us to understand what it is a family might need and then be able to determine risk and safety based on those conversations at a deeper level, or if there's services that we could provide.
Thank you very much. Go ahead.
Also, in regard to strategic goal number 2, you'll hear me say it here and you'll hear me say it again in one of our operational goals is we're looking to IT modernization to help us extensively across the agency, and then also being able to use our resources across the whole enterprise. I think Ms. O'Connor gave you some examples yesterday with the eCare system. That's the new childcare ecosystem, which is multifaceted, but will allow parents to be able to do inquiries of what kind of childcare is available in their area. It'll allow providers to be able to engage with all of the requirements that they have, which I know you had a lengthy discussion about yesterday. And also for us to be able to understand resources and referrals. That's just one way that we can use technology to create more opportunities to connect people with the services that they want. Something that Ms. O'Connor may have mentioned yesterday was that 100% of the people looking for childcare need childcare. This is one place in the agency where it's not.
Director, I have one more question for you here.
Okay.
Representative Penn.
Okay.
Thank you, Mr. Chairman. You'd mentioned IT modernization, and it sounds like maybe that is across all DFS, not just childcare. I'm hoping. I just have had several different scenarios with constituents reach out and say, I'm having trouble with DFS because I submitted this document. They say they don't have it. A situation where a child was picked up by a dad and he had in his hand, he had a court document which was old, and he had an officer with him and who didn't have the information. And so what kinds of communication do we have with maybe law enforcement? Is increasing or improving our IT system, is that going to be helpful to help with those types of scenarios? If you could just respond, thank you.
Director
Sure.
Shree, go ahead.
Sure, Mr. Chairman, Representative Penn. I think the best example to answer that question, Representative Penn, is the overhaul we're doing of our case management system. And actually, it's a replacement. A few years ago, we received an appropriation from the legislature to replace the case management system on our social services side. And just based on the conversation that you mentioned, I'm assuming this was a child welfare issue. And that system will provide a lot more opportunity for improved communication. I can't speak specifically to law enforcement, but certainly we're creating portals by which parents can be able to look up more of the information. Providers can look up more of the information, but it will certainly streamline a lot of our internal operations. And then that's where, so much communication can break down is with pieces of paper on a desk that can't be uploaded into a system. The current system was built in '96. It really is not capable of taking in a lot of information. So a lot of times we have a combination of a paper case file and an electronic case file. So yes, the hope is that with the release of the WyoSafe system, which we should be standing up in September, we should be deploying the full system in September, October, in that timeframe, will help with some of those communication issues. If it's a child support issue, that's a different conversation, but certainly there's ways that we can streamline that as well, or can follow up with you.
Thank you.
Okay, go ahead and proceed, Director.
Also then in reflection of strategic goal number 2, which is concrete supports and the right services at the right time, is we have partnered with the Department of Workforce Services on what's called an integrated case management process. And this is benefit of some of the ARPA funding that was appropriated to us to test a new model of providing services to people who are traditionally difficult to employ. We piloted this type of approach in our child support program and saw success. Basically, what we understand is that there are some people who need a higher level of support and intervention in order to become employed. Looking at the model that we piloted with child support, we saw non-custodial parents who were in arrears increase the amount of monthly support that was provided to their families, to their children. So based off of that experience, we're working with a contractor using the ARPA funds to develop a model that helps first the Department of Family Services to understand a little bit more about what are the barriers that some of the difficult to employ face. Could be things like mental health issues, substance use disorders, et cetera, that then make it very difficult for the Department of Workforce Services to provide their employment programs. So the pilot, the goal of this is that through a more streamlined intervention between the two agencies, that then we see increased success, which for us means that people stay employed longer and that they are getting employment at self-sufficient wages. We're in the first year of it. The model's being designed, collecting all of the data from the local offices, working with Workforce Services on their processes. And then next year, we'll start to pilot it in a smaller place, and then we'll look at rolling it out statewide. It's one-time funding to be able to develop this model. The intent is that the model will be sustained because it will change how it is we do our practice in the field. So it really is training on a different way of case management. Right now, it's very siloed. It's a cold handoff in a lot of cases. Here's your referral. Go find the Department of Workforce Services. This thinks a little bit more intently about what those barriers are first, and then working with the Department of Workforce Services to transition those clients to their programs. Strategic goal number 3 is really focused around vulnerable adults. Last year, there was a lot of work done by the Mental Health Task Force, and certainly the legislature supported a lot of the legislation that came as a result of that work. The Mental Health Vulnerable Adult Task Force is continuing and thinking a lot more about what services are actually available to vulnerable adults in a community. So a lot of our strategic goal is around identifying those services. They're different in every community. A lot of it is looking at developing capacity around our adult protection teams. So statutorily, there are teams, community level teams that come together and can work together to, one, identify resources, but also identify adults who are maybe at risk of vulnerability, at risk of abuse or neglect or exploitation, and hopefully provide some case management or connection to services as a result of those adult protection team conversations. Working with adults is very different than working with children, as you can imagine. But beyond the obvious, with our abuse and neglect cases, we have long had laws on the books about how we engage with those families legally. There's a process, the federal government has set out process, the state has codified a lot of those processes. Basically, there's kind of a guidebook or a playbook when we encounter a child who we believe may be at risk or has been abused or neglected. We don't have that kind of structure in terms of any federal support or any statutory support really that helps us go through those steps for the adult protective services side. And that's intentional. It's intentional because we are in a careful spot and we have to always be very cognizant of the rights of those adults. So adults have the right to make a lot of their own decisions, and they may be decisions that we don't necessarily agree with. as you know, as working with my elderly mother right now and going through some very difficult conversations about her healthcare. She has the right to make a determination about what she wants. And while she's open to my opinion, it's her life, it's her world, and I need to recognize that and respect that. So then when we find an adult that is choosing to live in a home that is maybe full of mess, but it's out in the country, they don't have running water, they don't have really good, reliable heat or some sort of energy source. It's those situations where we have to be very careful that we're not stepping on the rights of those adults, but at the same time, we're trying to connect them with services so that they can stay there for as long as they possibly can. For DFS, what that means is connections to all of the community resources. We have a very small budget for these services, $80,000 a biennium. What we do is a lot of the case management through our caseworkers out in the field. The Department of Health has the lion's share of the funding available for services for these vulnerable adults. And as the interim works out, you'll see us trying to connect those services a little bit better so that in any given community, we know what's there and we know our caseworkers know where to go, who to go to, and certainly others are also part of those conversations. So strategic goal number 3 is really thinking more about vulnerable adults as a system, and but recognizing that it is going to be a different type of intervention. Moving on to operational goal number 1. Moving on to operational goal number 1.
1 second. Representative Warnock, go ahead, sir.
Thank you, Mr. Chairman. A question for you on that strategic adult aspect of your services. I'm just curious. I know that we passed a bill last session, kind of expanding the definition of who falls into this category for these vulnerable adults. And I know that it hasn't yet really taken effect, but I'm curious if you are expecting any expansion in the number of people served because we've expanded that definition of who a vulnerable adult is.
Director Schmidt, back to you.
Mr. Chairman, Representative Warnock, we didn't directly change the legislation around the legal definition of vulnerable adult. That stayed the same. What we talked about more though was who to notify and who notifies us. So that was one piece of legislation whereby we closed a loop between DFS and law enforcement to make sure that those reportings were occurring. That may be one way where we do see increased caseload. But despite the legislation that was passed that has not yet taken effect, we're seeing an increase in reports of vulnerable adults. So that trajectory is happening regardless, which is one of the reasons why I think the conversation is very timely, is it is becoming a larger part of the work that this agency does. And as I said, we rely so much on our partnerships to make that work happen, and we need to do better, know more about what those relationships are so we can connect those adults immediately. Also, thinking about vulnerable adults, while I've been talking a little bit more about elderly, this also includes adults who are young that may have disabilities that are also vulnerable. And the services that they need can be entirely different than the services of somebody who's elderly, housing being an example. But certainly, do I think heightened awareness around vulnerable adults in general will create increased caseload? Yeah, probably, but also just our demographics, our aging population, just proportionately, we're going to see more and see more need.
Okay, thank you. Go ahead.
Strategic goal.
Hold on 1 second, Director. I got one more question here from the other end of the table. Representative Penn.
Thank you, Mr. Chairman. Director Schmidt, I'm just looking at number 3 and kind of hearing some of the things that you're saying. The success will be measured by an increased number of people receiving supports. And I understand where you're coming from. I mean, theoretically, if we're having an increased number of people, that means we've reached more people who needed services. But I'm wondering are we looking at all to find, I mean, in my opinion, success is achieved by getting people off of these services because we've delegated them, we found placement for them within the community. Are we looking at any kinds of direction or outreach to community members or community programs that aren't state funded and state run that is trying to help handle some of these populations and so that they aren't just becoming a responsibility of the state?
Director Schmidt, go ahead.
Chairman Baldwin, Representative Penn, yes, that's part of the strategies as well. It's trying to make some connections to the totality of support. So when we say supports, we're not meaning just government. We're meaning any of those other those supports that come through philanthropic organizations and certainly through churches. And at a very informal local level, our offices work extensively with churches and congregations. There's many congregations that will adopt a local office and provide, for example, a closet full of clothing and necessities for children coming into foster care. What we're hoping through a lot of those informal conversations, but more importantly, the emphasis on community, is that we can connect churches, congregations, and other interested folks with vulnerable adults, because a lot of what they also need is some socialization. So it may not just be an economic support, but it may be an emotional support or some sort of social support, because what we know is that so many of these vulnerable adults are very isolated. And that's not something that you can necessarily purchase. So yes, part of the mechanism for that are the family resource centers that Ms. Davis spoke to yesterday, which is kind of a type of thinking around a community collection of services where people can go not just to look for services, but also to volunteer their time. And then we also really reinforce 211 as a way to have a central repository to figure out that interest. Oftentimes the trick is there's demand and there's supply, but it's connecting those two through human services programs that gets pretty tricky.
Very good. Go ahead and proceed.
Okay, on to operational goal number 1, improving employee recruitment, retention, and satisfaction. This is an organizational goal, as you can imagine. We've talked a lot, the state has talked a lot about recruitment and retention since COVID. I believe our agency has bounced back quite a bit. Our current vacancy rate as of this point in time for March, and this looks back at February's pay, was at 2%, meaning we had, I think, 13 vacancies available. What we're also paying even closer attention to is our turnover rate. And what we know in our agency is that our work is done best by people who have been working for us for a while. So looking at that 2 to 5 year retention period is a big focus of what we're doing around this goal. We need people to stay with us and to work with us for a long time, because it takes a while to understand all the programs, all of the policies, and really just the experience of doing this kind of work. Our turnover for the last 12 months is 16%, which is fairly low. Where we pay really a close attention is on our social services side, and that turnover is below the national average. But we did experience a lot of turnover, and we do have a lot of new employees. And now, as part of this operational goal, thinking about then keeping those employees and building onboarding programs that make it easy for them to transition into their jobs, building training programs so people feel like they have the tools they need to do their jobs, and then also to provide ongoing support. A lot of the work that is done by the field, a lot of what they see, a lot of the problems they engage with, a lot of the stories that they hear are pretty traumatic, and they can wear and tear on anyone. And so we want to be also aware that as an ongoing support, also providing what they may need as a result of just doing their day-to-day jobs. So we're looking at a handful of strategies to address that. Certainly, I think the increased wages helped, at least from a social services perspective. It made us a little bit more marketable. But that was, I do think that that's one of the reasons why we've seen our vacancy rate kind of settle down. And then so it's up to us to keep people. I do have to say, though, that while our vacancy rate is low and our turnover rate is low, we do see fewer qualified applicants. And I was listening to the UW conversation as well, and we don't know why that is. We don't have any of the data tell us that, other than just the assumption of fewer people in the age group that we typically hire, which are younger people. There's just fewer of them in the state. Again, another reason why retention is important. Operational goal number 2, which is modernizing and leveraging IT and business process solutions to improve client experience. We hit on that a little bit just a moment ago, but to also give you some idea of how extensive our IT modernization is. In this next calendar year, we're going to deploy WyoSafe, which is a new case management system. We are going to deploy eCares, which, as Ms. O'Connor explained yesterday, is our new child care kind of ecosystem system. Per legislation requirement a few years ago, juvenile justice information system will be deployed this year. And then we've also been working on the early childhood integrated data set, which is a system that we're supporting right now through grant dollars. You all appropriated some money to us to continue that effort, and we'll be working on bringing more data into that system. So real heavy on the IT in our agency, which was long overdue. Most of our systems, our 3 big systems are all built in the 90s, and we're modernizing 2 of them. Our eligibility system is still going through modernization. That's coming in phases. That's not a single replacement. We're doing that over time. The next phase of that modernization will include things like online applications, we hope, for our benefits, and better, smoother use of that technology so that clients can engage with us a little bit better. Document uploads, that type of thing. Moving on to operational goal number 3, improve access to timely, accurate, and meaningful fiscal data. The legislature appropriated some funds to look at the budget system, IBARS, sorry, it took me a minute. Looking at IBARS, that speaks to one of the ways where we hope there's some modernization. We spend a lot of our time doing a lot of manual fiscal work, lots of spreadsheets. We're looking for ways that we can modernize those, looking for more electronic systems that will help us. Our agency does an incredible amount of federal reporting to a lot of federal grants. And because of the nature of the dollars we receive, the type of funding we receive, we go through an extensive cost allocation process, which just recently moved on to an electronic system. We stand alone from a lot of the other agencies in that federal responsibility. So reporting is very difficult for us. So our fiscal team is continuing to look at ways to be able to pull that data in and then turn it around to administrators so that they can better manage budgets, better understand where their money is going real time. We do it after the fact, but real time makes us that much more flexible and agile. And then our last operational goal is to improve department use of quantitative and qualitative data, including user experience and voice. And as you all know, you ask us for a lot of information, and we ask ourselves of a lot of information. So we want our overall agency to be more comfortable with understanding data and using data to help inform policy decisions. Data isn't the only thing to consider, but it certainly helps from a number standpoint to understand a little bit about the problem so that the strategies are more applicable. But that creates a culture. We are a human services agency, so we depend a lot and rely a lot on relationships. Pulling data in some sort of quantitative analysis sometimes is a little tricky for us. So this is just an ongoing, will always be part of our conversation about how and where and when we can use and understand information that we collect in ways to improve our services and to provide input on policy. So, Mr. Chairman, it's 12:23, and I know there's many of you who are probably anxious to get going, but certainly we're here to answer any questions.
Any questions, committee? Representative Penn, go ahead.
Thank you, Mr. Chairman. So let's see, where's my question? So looking at data and different things, do we have ways to, or are we examining the various services that families or individuals can be on? Are we, when we look at those and offer those, decide what eligibility is, are we looking at each individual program individually with their, eligibility and such specifically? Or do we ever step back and say, okay, they're receiving childcare assistance for $450 a month. They're getting SNAP assistance for $800 a month. They're getting this and this. Do we ever step back and say the amount of services or the amount of benefits that we're offering equals this much? Or are we only looking at them individually?
Director Schmidt.
Chairman Baldwin, Representative Penn, this is kind of a technical response, and then I can get into what I think is the bigger response. The programs that we manage, for the most part, that come with some sort of eligibility criteria are federal. So SNAP is a federal program, TANF is a federal program, Child Care Assistance is a federal program, LEAP is a federal program. So by administering those, by being charged with the administration of those, if a client is eligible, then they receive the benefit. So they have to apply, they have to be eligible, they have to maintain eligibility. If they're doing those things, then they continue to receive the benefit within the program timelines. For example, with TANF, TANF is a 60-month lifetime benefit. So somebody who's on TANF, cash assistance, they can only receive that benefit for 60 months, 5 years. After that, they no longer receive it. So there are some programs that will be eliminated or come to an end because of eligibility. Others, though, like LEAP, SNAP, are always going to be based on, do they meet the criteria? If yes, they're eligible and they're complying, then they'll continue. So in terms of stepping back and saying, okay, how much is this family getting? Not necessarily, because there isn't anything we can do to not give them the benefit, if that makes sense. So we can't say, well, you're receiving X number, so therefore now you're not eligible for TANF, or now you're not eligible for SNAP. Certainly part of that basket of goods is important in understanding that basket of goods, and that's a lot of what those concrete supports are about. But to quantify those and then make a judgment call whether someone or somebody should or should not receive it, no, we don't do that.
Follow up.
Thank you, Mr. Chairman. So as a state, could we say, let's add the cumulative of what we're actually dispersing with their actual incomes? Because hopefully these people are still working and working to improve themselves as well. We couldn't say not to exceed the state median income.
Director.
Chairman Baldwin, Representative Penn, not per federal guidelines. If somebody's entitled, they're entitled. What we could say as a state is that we don't want to participate in X program. So, you know, that's a major legislative policy question, but we could not participate in SNAP, for example. But how much the benefit is and who receives it is dictated by federal guidelines, laws, and regulations.
Okay, one more follow-up, Representative Penn.
Thank you, Mr. Chairman. So I think I might know the answer to this question too, but how do we currently determine what SNAP will and will not pay for? What can it be purchased with, or what can be purchased with SNAP funds, what cannot? I just know, look, say the app that Smith's grocery store puts out, you look at that app, each individual item on there, it will say eligible for SNAP, eligible for SNAP. And there is nearly nothing in the grocery store except for hard liquor that SNAP will not pay for. Yesterday, we had a discussion on the rising rates of obesity. And here I'm looking and seeing some of these things. It's soda pop, it's licorice, it's all the junk food. You can use it at 7-Eleven that we're spending tax dollars, essentially, in my opinion, funding obesity in some ways. So is there any way as a state that we can look at what it will cover? It seems like if this is a state benefit, we should focus on the basics, things that are healthy, fresh fruits and vegetables, those types of things.
Director Schmidt.
Chairman Baldwin, Representative Penn, what is available or what is allowed for purchase are federal requirements. So the feds purchase the foods directly. Those dollars don't come throughout our office, our budget. We administer the program. Through the guidelines set by the feds, we make the determinations for eligibility and the amount of food benefit they receive. We then send that information to basically a electronic benefit transfer company who then get the actual dollars from the federal government to load onto those cards. So the money goes directly from the federal government to the person. We don't control what they can buy for it as a state. What the federal guidelines do not allow is purchasing of prepared food. So hot food, non-food, it has to have a food label. And all of that work is done through the transaction system. So the EBT card and the systems that a lot of the grocery stores have that then make the determination, or they're the ones that check. It's that system that checks, is this an eligible food purchase or is it not? What the feds give us is money for for sensible nutrition. So to get a little bit more at the nutritional component, we contract with the department or the University of Wyoming and their Sensible Nutrition program to provide education, cooking skills, all of those things so that the recipients have a chance to understand better and more about their nutritional food choices. And it's through education then that we would hope they would make better food choices and purchase foods that go longer, you know, a bag of rice compared to some instant rice, those kinds of trade-offs. But in terms of what the state does, we can't regulate what they purchase.
Okay, further questions, Representative Hornock.
Thank you, Mr. Chairman. Along those lines, I know that I'm curious if there are work requirements related to some of these benefits. I know that in some instances, you don't necessarily want that when it comes to maybe childcare services or things like that. You want somebody to be taking care of that child. But I'm curious if on the state level we have an ability to require some, you know, an adult to be working to receive services, or if, again, with the federal funds, that's something that regulated with the federal, on the federal mechanism that we don't have any control over.
Director, go ahead.
Thank you, Mr. Chairman, Representative Hornock. SNAP comes with work requirements for a group of people called able bodies, able to work, and I don't remember. Able-bodied adults without dependents, ABODs. And I think you've heard us use that term previously. We've had questions about that. And ABODs are people who we think and the government thinks should be able to work. And if they're not working, their benefits are limited to 3 months. So there are work requirements. However, there's also exceptions. So there's an exception due to age, due to disability. There's a laundry list of things that would make somebody exempt from having to work. And those are listed per federal requirements. If we wanted to add to that list, I think that'd have to be a legislative conversation. I don't know who else we would add to that list because it's still going to be income-based. So that's primary, that's income-based. And if you're able to work, we require it. And if you don't, then you don't get the benefit. Tanif, sorry to
Follow up,
continue on.
Representative Hornock. Go ahead, Representative Hornock.
Thank you, Mr. Chairman. Just back on that, and then I have some other questions. Is there, on that work requirement for SNAP for able-bodied adults, is there a set number of hours? Is it 40 hours a week? What is the specific requirement?
Go ahead, Director.
Mr. Chairman, Representative Hornock, an ABOD must work at least 20 hours per week or 80 hours a month or participate in a qualifying education or training program, such as the SNAP Employment and Training Program.
Thank you for the follow-up. Go ahead.
Yeah, thank you, Mr. Chairman. So a different topic back on the dealing with the safety of children, youth. Have you seen an uptick? I'm curious within the state of Wyoming over the last, I don't know, number of years where I'm curious just how things are going, the temperature of what's happening in the state of Wyoming with the Child Protective Service realm. Do you see an uptick in the number of children that are involved in this program with the number of children that are court-ordered placements and what's happening with those, the number of children going into the adoption process, that kind of thing. I'm just curious what the trend is right now with that.
Director Schmidt, tell us the trend.
Mr. Chairman, Representative Hornock, yes, we're seeing an increase in all those things you've mentioned. We saw a pretty good dive in a lot of our reporting during COVID. Our primary reporter of abuse and neglect are schools. So when many of the kids weren't either attending school or attending online school, the number of reports we received went down. Those are all coming back up. Yes, we're seeing increased reports of abuse and neglect and increased number of children coming into care.
Very good. Representative Yen.
Thank you, Mr. Chairman. Director Schmidt, I apologize for missing much of the agency report, but one thing I'm curious about, and this is, you don't have to have a number for now, but maybe something for the next agency update at the next meeting. I'm curious on whether the Medicaid birth cost recovery program is finally recovering more money than it actually costs to administer. I know in our last supplemental budget, we actually increased the amount. I think we gave money to the Attorney General's office. So being able to loop in all of that administrative costs would be really helpful for us, I think, to make a decision on whether that program is working well or not. So if you could, just bring that for our next meeting.
Mr. Chairman.
Director Schmidt.
Mr. Chairman, Representative Yen, I have those numbers if you'd like them now, or I can send them to you.
Sure, now would be great, Mr. Chairman.
Very good. Thank you. Representative Warnock. Oh, hold on one second. Director Schmidt, go ahead.
Okay, so there were 59 million in birthing cost expenditures referred to DFS from July 1st of 2018. So when the law went into effect, and this is information through February 2nd of 2024. Excuse me. Of these, 517,000 in costs have been recovered, birthing costs have recovered, but we've had 435,000 in administrative costs. So we are now recovering more in birth costs, but the majority of it is still going to administrative costs. And and I apologize, there's one little side note. What we recover is then split 50-50 with the feds because of the programs of the Medicaid program. So we'll send these to you because Christy can say it much more articulately than I can.
Good follow-up, Representative Young.
So, Mr. Chairman, then just to confirm, you're saying that if we're splitting 50-50 of what we're recovering, we still put back in Wyoming's bank accounts less than we are expending. So we're still spending more state dollars than we're recovering in state dollars. Is that correct?
Director Schmidt.
Mr. Chairman, yes, that's correct.
Okay. Senator Hutchins, go ahead.
Thank you, Mr. Chair. I'm trying to understand a lot of these programs. Is SNAP just a new nomenclature for welfare? And then if you're getting SNAP and if you're getting WIC, what is the greatest difference between the two programs?
Director Schmidt, go ahead.
My understanding. Thank you.
Mr. Chairman, Senator Hutchings, SNAP is formerly Food Snaps. So it's the Supplemental Nutrition Assistance Program. And how that relates to WIC is for women, infants, and children. So SNAP is for the greater population, the bigger population. WIC is the population that they serve is limited to women, infants, and children, I think 0 to 5 years old. WIC has a kind of a prescribed food plan based on the nutrition needs of the child. So that is done through, I think, a registered dietitian. They have people that are trained to help determine what that food package should look like. SNAP, as Representative Penn pointed out, could be used to purchase a whole variety of foods. Welfare, as we used to know it, is now called TANF, Temporary Assistance to Needy Families. And that's a block grant we received from the federal government that we then allocate for different types of services. Did that answer the question?
Follow-up, Senator Hutchins.
Thank you. Yes, it did. And I thank you for the clarification. So just knowing of people who are on these programs, when I've seen one actually go to a bank and put in a card and get cash, which program is that out of the three? And then are you working to lower the people getting TANF as much as possible? Thank you.
Director, go ahead.
Thank you, Mr. Chairman. Senator Hutchins, I'd maybe like to answer your last question first and explain a little bit about TANF. So the Temporary Assistance to Needy Families has kind of two different programs. One is cash assistance, and that's typically the program that I think we think about when we're thinking about cash. And there's two types of people who are eligible to receive TANF cash assistance. We call that program in our state POWER. So with that particular program, we have two types of qualifying people. We have people, mothers with children, parents with children who qualify. And then we have people taking care of children. So they qualify because they have a child in the house. The example of those types of families are grandparents taking care of grandchildren. So We call that the caretaker relative program. Out of our total cases, on a monthly average of households receiving TANF assistance, cash assistance, POWER is what we call it, there's 468 households on average that receive some sort of TANF cash assistance payment. Of those, about 53% or 246 are participating in the work program. They're required to work and they get referred to the Department of Workforce Services for employment services, or they may go to another type of employment program. The caretaker relative program is 222, and these are all averages at any given time, 222 of the cases, so about 47%. And again, like I said, those are guardians usually taking care of children that are then qualifying because of taking care of that child. In terms of, are we helping to look for ways for them to find self-sufficiency? Yes. That goes back to the program that I was mentioning with Workforce Services, that integrated case management program, where we really do want those families to be able to be self-sufficient, understanding that they may have more barriers than others do. A good example of a program that is highly effective is Climb Wyoming, which works with single moms and their children on employment programs. We use TANF funding to help support that program, in addition to others, like some trucking companies. We provide school trucking companies, so clients can learn a trade in other various employment programs. In terms of the card thing, and who may be receiving cash, we do put child support dollars onto EBT card or onto benefit transfer cards. So there may be a person that's withdrawing money from a card, but it's the child support that was gathered from the non-custodial parent and paid through on a card.
Fascinating.
Follow-up, Senator Hutchins.
Thank you, Mr. Chair. I really appreciate that. And I love Climb Wyoming. And I heard you say that you use TANF dollars for that as well to support Climb.
Director.
Yes, Mr. Chairman and Senator Hutchings, I should have continued my TANF conversation. So the cash assistance, the POWER program, is just one small component of the overall TANF block grant. So we receive about $18 million a year in TANF block grant funds. And those dollars are spent, first and foremost, we're required to provide cash assistance, to manage a cash assistance program. So we provide funding for that. The majority of the dollars, though, go for direct services out in communities. We use a portion of those dollars to support our social services system. So children who are TANF eligible in social services, or families that are TANF eligible who are in social services, we use a portion of those dollars to provide them with services. We provide money to the Department of Education for the TANF preschools. We provide TANF money to the Department of Health for home visitation. We provide money to counties, local government, who then distribute those TANF dollars based on application to them. And then we have direct contracts with entities like Climb, the DADS program at the Department of Workforce Services, Sage Trucking, and other similar programs. So the majority of the block grant funds that we receive actually go to direct services in communities to serve people who would otherwise qualify for TANF, but they're not getting, but it's not a cash assistance program. It's a service on their behalf.
Okay, final follow-up.
Can you get all three? WIC, SNAP, and TANF?
Director Schmidt.
Mr. Chairman, Senator Hutchings, you can receive SNAP and TANF, yes. I don't know if you can receive SNAP and WIC at the same time? I don't think so, but that would be a Department of Health question for sure, to know that for sure. The Department of Health manages the
Representative
WIC program.
Penn. Okay, Representative Penn.
Thank you, Mr. Chairman. Something that you just said a bit ago kind of jogged my memory. So you say that these are all programs that would require someone to enroll in. That would require me to go submit an application or fill something out to apply to these programs. I was reminded that a few years ago, I had a EBT card show up in the mail addressed to one of my daughters. I have 3 kids. It was to one. And it said, this is your EBT card. This is how you can spend the money. And how would that happen? Because of course, that's not something that I've ever sought out. So if I didn't do it, how did I get a card in the mail?
Director Schmidt.
Mr. Chairman, Representative Penn, that probably was the summer EBT program, the electronic benefit program, or the pandemic EBT program. So at the very beginning of the pandemic, the federal government provided funds for children who qualified or somehow were on free and reduced lunches. And what in partnership with the Department of Education, we sent out those cards to anyone who was on those lists. So that was not an application basis. It's just you received them because that money was available. That was a one-time program that wouldn't continue.
Follow, Representative Penn.
So if my kids are not on free and reduced lunch, and I have 3 kids, one of which at this time was not in school, but 2 were, and I got 1 card, I'm still having a little trouble figuring out how that would be, but I guess I don't know. Thank you.
Any clarification, Director?
Mr. Chairman, Representative Penn, we use Department of Education data. So there could have been a number of issues. That was a very fast program. It was stood up very quickly. There wasn't a whole lot of guidance. The aim was just to be able to get food benefits to families. So there was always a chance then that maybe if you had received 2, that you only received 1, but I don't know specifically why.
Okay, Senator Hutchins, it wasn't your final last time. Go ahead.
No, it was Representative Penn who brought this about. Corinne, just an idea, how much was on that card? And could anybody use it without any, what's the word? Thought of who's using it? Yeah.
Director, go ahead.
Mr. Chairman, Senator Hutchings, that program is no longer available. It was a one-time program, but at the time, yes, whoever had it could have used it. Yes, whoever had it could have used it.
Wow, thank you.
Representative Warnock.
Thank you, Mr. Chairman. Bit of a philosophical question, I suppose, to just know how you make some determinations, but I know that in a big way, the ultimate goal when you deal with child protective services, child care type of situations where you have to remove a child from a parent, the goal seems to always be to get that child back to their birth parent, essentially. But seems like many situations, that is not a great place for that child to go. And so I'm curious how you thread that needle, how you navigate that when if there's some standards, because a lot of the success metrics are based on getting that child back with the parent, whereas maybe there was a very good reason that child was removed from the parent. And so I'm curious, just, how you look at that and what you do in those situations, because it's not, you know, it's not always the great place for the child to be.
Director Schmidt.
Chairman Baldwin, Representative Hornock, I think that's a really good question. And it's the question that Joint Judiciary is asking of us. And so we'll be ready to present a lot of that information at the June meeting. And I don't say that to put you off, but just so you know that there will be more materials and information coming out in preparation of that meeting if I'm not able to kind of get you the answer today. In short, the social services part, the child welfare that you're talking about, and specifically abused and neglected children, the process that we go through is mostly legal. There's some judgment calls, and then those calls are made by a group of people. So just to kind of quickly walk you through how that could happen. The authority to remove a child is with law enforcement or medical personnel. So DFS doesn't have the legal authority to go in and remove a child from their parents. We do that. Most of the time, law enforcement will consult with us and medical personnel will consult with us, but the legal definition of removal is with law enforcement and medical professional. They then turn around and give us the child for placement in a safe place. So that's really where we start to get involved. It's at that time then, if a child comes into protective custody, there's kind of a time clock that starts on legal proceedings then that make determinations about how that case will go. So that child comes into temporary custody of the state, and then we go before a judge and lay out all the reasons why we think the child should either be returned or the child should go back or should stay in protective custody. If a child comes into protective custody and the state does take full custody, then what is formed is called a multidisciplinary team. So the court appoints a group of people to basically be those who inform the case plan for the family. They'll work for the family. There's legal representation for the parent. There's legal representation for the child. DFS is always there. They may have a mental health therapist that's assigned to the MDT. There may be education assigned to the MDT. And then that MDT works together to make recommendations on then that case. So how is the parent doing? How is the child doing? They talk about visitation. Is a parent ready to have visitation from their child? But over all of that, under our requirements comes this goal of reunification, which is what you were talking about. And so reunification is really where we try to start thinking about really that safe at home. What does that child need? Meaning, what do the parents need? What does the family need? What does the child need? What needs to take place in that home for that child to be safe at home? And as the case plan moves, or as this case goes through court, the multidisciplinary team is monitoring the progress of the parent and the child, and then providing on a pretty regular basis recommendations as to next for what's next. The MDT recommendations go to the judge, and then the judge makes a decision whether they adopt the MDT recommendations or whether they have a different outcome that they would like to see. But underlying that is always this idea about reunification. And then if a parent within 15 months or so hasn't demonstrated what the parent should be demonstrating for that child to return home, then we'll look at what's called termination of parental rights. And if the decision is made to proceed with termination of parental rights, that's another hearing. The judge makes the decision as to whether or not those rights should be terminated. If those rights are terminated, then the child can be available for adoption. Interwoven to all of that is something called reasonable efforts. And the law holds us to the reasonable effort standards, meaning that the department has to demonstrate it made reasonable efforts to reunify that child. And so that's another place where you start to think about balancing the rights of the parents, because this is a parental rights issue as well. It's a balancing of parental rights issues, children's welfare issues. And so this team of this multidisciplinary team is working together all the time, trying to determine where that balance is, and then whether a child should be returned home because parents have done everything that they've been asked to do and they show that they can take care of their children safely at home, or if they can't, then discussing potentially adoption. When a child comes into foster care, when a child cannot stay safely at home, one of the first things that we do is look for somebody the child knows to stay with. So a kinship placement, family, friends, somebody that the child knows. Because that event of taking a child away from his or her parent, regardless of the abuse and the neglect, is also a traumatic experience. And it may be in that child's it may be in the best welfare of that child to do that. But what the child isn't recognizing is that we have this standard that says we're going to take you. What they recognize is that they're not at home anymore. So we really want to be careful in understanding too the traumatic effect that can have on a child and long-term effect. And then by hopefully placing with somebody that they know, there's some familiarity. They're not going to a stranger's home, you know, strange house, unspoken rules in a situation where they just have been taken from everything that they know. So there's some very careful steps that we take. And when I say we, the system, all of us together, when removal is either imminent or is being considered. And then that's then follows a very legal process after that.
Follow-up.
Not a follow-up, different question.
Okay.
You've got over 600, 700, almost 700 employees in your department. I'm curious how many of those employees are working from home still, and if there is you have a goal of getting them back to the office, or if they will continue to work from home. And then also if you have, if it's your belief that the productivity level of somebody working from home is the same as somebody working from an office. Thank you.
Director Schmidt.
Mr. Chairman, Representative Harnack, I can't tell you specifically the number of people we have working from home and working from the office. But the policy of the department is that we have a hybrid approach to telework. And so that decision is really made based on the work that's done, what is required of the staff person, and where can they best do that. For example, at the boys' school and the girls' school, we don't have telework because the work that they do it requires that they be at the facilities. However, for some of our program and policy people, they can do a lot of their work via telework. Meetings are held virtually, et cetera. So I think in answer to your question about productivity, it really depends. I know, for example, like our fiscal services unit does a lot of things where they are required to have intentional focus. They're working on a lot of numbers. They need uninterrupted time. That's sometimes hard to get in an office setting, but they can get it at home. However, we also have caseworkers that are getting called in the middle of the night that then with telework capabilities, they have access to what they need to be able to access the systems so that they can immediately go out, compared to before COVID, where they would have to go to the office first. So it really is depends on what they're doing. And I was just given some information about the numbers that we had compiled for December for JAC. As of December 2023, we had 408 telework agreements with a staff of about 650. 14 of those telework agreements were full-time, meaning they didn't have an office that they went to. 128 were part-time. And then 260 were intermittent. So part-time means is that they have a schedule in the office, out of the office. And then intermittent is as needed. So for example, on snow days, we would have an intermittent telework agreement so that that person could work from home during a snow day. Does that provide you with the data you need?
Okay, Representative Young.
Mr. Chairman, thank you. Director Schmidt, you know, thinking about the topics that we had yesterday, especially with regards to childcare, and I know that your department probably has more women and more folks that are of childbearing age. Do you think that having childcare facilities or options for state employees would help with recruitment and retention and possibly productivity for your department?
Director.
Mr. Chairman, Representative Yin, what we know is that childcare is an essential component of any labor force. And yes, what the Department of Workforce Service or the Department of Family Services has is typically a younger workforce who are childbearing age, mostly women. We are the agency that employs the majority of women as a proportion of its overall employment. So is access to childcare an important component of recruitment and retention? Absolutely. To answer your question about does that need to be state provided, that's a policy question. But certainly just having access to childcare in general is essential for our workforce. And we do see young families who moms have children and decide to not re-enter the workforce because childcare becomes a barrier. I couldn't give you numbers, that's anecdotal, but yes.
Very good. Committee. No, I think that's all. Okay. Okay. Thank you very much, Director, for joining us today. Our thoughts are with your family. Best to you. That was a pretty good sacrifice to join us. Thank you very much. Okay. I'm assuming there's no public comment out there. I know there's none in the room. Okay, none online. Okay, committee, that completes our day. Are there any thoughts this afternoon you've heard about Witchy, Whammy, DFS? I heard a lot of things about Witchy, much and Whammy that we can't do a lot about. Funding has to go through JAC. Talked about veterinarians, if that's anyone's desire to deal with that. Any thoughts or directions to LSO committee? Go ahead, Representative Paulson.
Thank you, Mr. Chairman. I had a real world kind of situation come up. I don't know if anybody knows, but in Wyoming, the only two professions that can provide a handicap placard are nurse practitioners, advanced nurse practitioners, and physicians. So MDs and DOs. So in my building, I have a physician assistant. She couldn't write it for the handicap. The podiatrist who did the surgery couldn't write it. So just looking at some of these other states, maybe we need to add some other physicians to, or other healthcare professions that can write the.
Would you like to make that a motion and have that bill drafted?
Put an agenda for.
Put it on for June?
I'll bring all the information in.
Okay, let's do that. We'll put that on the agenda for the June meeting in Pinedale and address that time. Oh, go ahead, Anna.
You want us to draft a bill or just have it on the agenda?
Let's just put that on the agenda. We'll draft a bill at that time.
It should be pretty easy. I mean, if we decide to do it, it'd just be adding some professions to it.
YDOT has an office of civil rights that it falls under and you could invite them.
Okay, thank you.
Correct. Okay, anything further? Let's go to LSO. Tell us what we've asked of you over the last 2 days and make sure we got it all.
Sure, Mr. Chairman, just give me 1 second. We have a motion for a bill draft regarding the Healthcare Authority, and then another bill draft to prevent state money from being used for sexually explicit events, as well as federal funds. A motion to resurrect House Bill 62, which was the opioid Good Samaritan bill draft. For research, we have research on what other states have done regarding tort reform, research regarding additional cross-training and gaining extra specialties for physicians, research on increasing the Medicaid rate and upper payment limits, You want us to reach out to the community colleges to see what it would take to set up a midwifery program. Research regarding actual numbers on how many doctors are going to leave the state. And involved in that is asking Medicaid how many providers have disenrolled and said they'll no longer accept Medicaid. Then we also have draft legislation regarding nannies being able to serve up to 5 households. And then we have an informal subcommittee to get with Josh Durrell and other business leaders to talk about issues with childcare. And then we're going to have a working group regarding provider enrollment, and then a bill draft for some of the provider enrollment issues, including back pay requirements and expedience on credentialing, a 60-day time frame, things like that. And that's pretty much where we are as far as tasks go.
The only thing that comes to one thing that comes to mind was the South Dakota, Nebraska issue with the OB and the general practitioners, if you would. Anything else, committee, miss? Go ahead, Senator Bouchard.
Thank you, Mr. Chairman. So I get emails occasionally from people with chronic pain, and all of the, not from what we do, but what's happened is, since we've changed so many things, it's created a problem for them. So last November, they put out new guidelines, and I would like to see if LSO can research to see if that flexibility or what we have to do to add that flexibility in, so doctors have that have other options.
You're talking about other options
for prescribing
outside of opioids, is that correct?
No, inside that realm.
Oh, okay.
Because we have patients that are, that are seeing doctors for chronic pain, and they are having to do things outside of the norm to even the doctors are doing things to try to help these people that are probably outside the norm because of the laws we've created. So I'm just trying to see if maybe the guidelines that they released in last November, if there's something we can do and maybe change some of that for the doctors that just treat the chronic pain.
So what they could do is research what the current guidelines are and what changes have been made, and then can see what the problem is.
And if we have to fix them statutorily, yes.
Right. Very good. Okay, if that's it, committee. Let's call it a day. Y'all can travel home. Okay, thank you and I hope you enjoyed Afton.
Lovely.
Okay.